Hello, everyone. I'm Lillian Kell, President of IFSO, and I have the pleasure of welcoming all of you together with Professor Guilherme Macedo to the World Digestive Health Day 2021. Today's program is a culmination of a collaboration of two international federations. IFSO, the International Federation for the Surgery of Obesity and Metabolic Disorders, and WGO, the World Gastroenterology Organization. Our theme for this collaboration for World Digestive Health Day is Obesity, the Ongoing Pandemic. The aim of this joint campaign is to raise awareness of obesity as the ongoing pandemic and the impact it has on the development of comorbidities and subsequently the effect on life expectancy, which is just as devastating as any infectious pandemic. I would like to take this opportunity to introduce my co-moderator, Professor Guilherme Macedo. He's the president-elect of WGO and currently serves as chair of the WGO Foundation. He also served as the American College of Gastroenterology, the international governor for Portugal. He's currently the head of the Department of Gastroenterology at Central Hospital São João at the University of Porto. I will now invite Professor Macedo to say a few words.
Thank you, Professor Lillian Kell, and it is indeed a pleasure and honor for us to welcome all of you to this World Digestive Health Day 2021, as you know, dedicated to the obesity, the ongoing pandemic. The fact is that this is an extraordinary and evolving chapter in medicine and surgery that prompted us, both WGO and IFSO, to build up this joint venture. And the fact is that also a major recognition of the importance of this topic, and also to the relevant role of those who have been engaged in this global health issue, is the United Nations Secretary General statement that publicly expressed the support and commitment to our project in addressing obesity for a sustainable and healthy world. So we have, and we believe that our faculty has created an outstanding program to keep you motivated and tuned in throughout these next hours to think and to reflect about how can we deal with obesity. Now I have to give also a special word of acknowledgement to our sponsors and partners who in fact made a very important contribution so that this project could be built up and shown to all of you throughout the world in this beginning of afternoon, at least here in Europe. Professor Lillian Kell, who will introduce the three panelists in our first session. As you know, she's the current president of IFSO, and she's a senior past president of IFSO Asia Pacific chapter and a senior past president of the Obesity Surgical Society of Australia and New Zealand. She's a senior consultant surgeon at Flinders Medical Center and clinical associate professor at Flinders University of South Australia. She has been involved in training surgeons in bariatric surgery nationally and internationally, as many of you know. She has been also at the forefront, along with her colleagues at the Adelaide Bariatric Center, in developing a very effective multidisciplinary program for supporting our patients in their weight loss journey. The program in Adelaide was one of the initial ones adopted in Australia and internationally, and the first to be used in South Australia. So thank you, Professor Lillian.
Thank you. Well, I think we're going to start the first session. And in this first session, we are going to discuss some of the hottest topics in obesity, including non-alcoholic fatty liver disease, cancer, and diabetes. So it is my pleasure, firstly, to welcome our esteemed panelists, Firstly, we have Professor Laurent Bieto from Canada, who is the clinical professor of surgery at Laval University, where he introduced minimally invasive bariatric and metabolic surgery. He's the director of the fellowship program there, and he's also the past president of the Canadian Association of Bariatric Physicians and Surgeons. So welcome, Laurent.
Thank you. Good morning.
Second on our panelist team is Nicola Di Lorenzo from Italy. He's the Associate Professor of Surgery at the Department of Experimental Medicine and Surgery, University of Rome, Tor Vergata. He's the former president of the Italian Society for the Surgery of Obesity. He's the member of the IFSO Executive Board and secretary of the European Association of Endoscopic Surgery. Welcome, Nicola.
Thank you. Welcome,
Last
everybody.
but not least, I have Syed Hamid from Pakistan, who is the chairman and professor of gastroenterology at the Aga Khan University Hospital, Karachi. He's the member of the Executive Council of the Asian Pacific Association for the Study of Liver and currently serves as president of the Pakistan Society for the Study of Liver Diseases. He has been a long-serving member of the WHO Guidelines and Publications Committee and chaired the WHO Guidelines Development Group on Hepatitis C Treatment Guidelines, which was released in 2016. Again, a very warm welcome to Syed to the panel.
Thank you, Lillian, and a pleasure to be here. Thank you.
Very good. Also, we are counting with our three presenters that will address these three different topics that will be discussed later on. And so for me, it's also a pleasure to introduce Professor Helena Cortes Pinto from Portugal. She's a specialist in gastroenterology, of course, and she's the vice president of the United European Gastroenterology since last October. She is dedicated predominantly to hepatology, particularly to alcoholic and non-alcoholic fatty liver, nutrition, and public health. She's full professor at the Faculty of Medicine in Lisbon since 2017, and her long-range activities include teaching pre- and postgraduate students. She's also director of a master's degree in clinical nutrition and coordinates several disciplines in the area of medicine and gastroenterology from the Integrated Mastership in Medicine and Nutrition Science. She is the director of Clínica Universitária Gastroenterologia of Faculty of Medicine in Lisbon, and she coordinates the hepatology unit of Centro Hospitalar Lisboa Norte, Portugal. Welcome, Helena.
Hello. Hello, everybody. Thank you.
We'll also have Dr. Raul Rosenthal from USA. He's the chief of minimally invasive surgery and bariatric surgery and the director of fellowship in minimally invasive and bariatric surgery at Cleveland Clinic, Florida, USA. He's the current president of IFSO, North American chapter, and member of the IFSO executive board. Welcome.
Morning. Thank you for having me.
And finally, but not least, we have Dr. Francesco Rubino from UK, who is the chair of metabolic and bariatric surgery at King's College London, and honorary consultant at King's College Hospital. He is one of the world's leaders in research, teaching, and practice of metabolic and weight loss surgery. He graduated in Rome at Catholic University, and he completed fellowships at the European Institute of Telesurgery in Strasbourg, Mount Sinai Medical Center in New York, and Cleveland Clinic. He is the recipient of numerous awards and given hundreds of presentations throughout the world, just like the one we are going to hear in a moment. And for several consecutive years, Professor Rubin was selected by many popular US News and World Report and Castle Connolly as one of the America's top doctors. Welcome, Dr. Francesco Rubino.
Good morning. Thanks for having me.
So dear attendees, please do sit back be comfortable and be ready for some stimulating presentations. At the end of the presentations, there will be opportunities for you to ask questions. So I'm going to start off with a poll. This is a question I'd like you to read and answer. You have 60 seconds, or 120 seconds to answer this question, which is on the first topic, which is regarding the prevalence of non-alcoholic fatty liver disease in obese individuals. What do you consider is the approximate percentage? So please vote using the dashboard on the right of your screen. While you're answering that, I might ask Helena to comment on non-alcoholic fatty liver disease as she sees them in her clinical setting. Helena, what do you think, how many of your patients you're seeing have non-alcoholic fatty liver disease?
Well, as I am really dealing with this pathology for a long time, in my hepatology clinic, I would say like 3/4 of my patients. Increasingly important is the percentage of patients that already have advanced liver disease. And in the beginning, that was not like that, but recently we are seeing increasingly patients already in the cirrhotic phase. So I really think this is a major problem, and it has been increasingly important, not only in the prevalence, but also in the severity. But I'm really interested in knowing what is going to be the answers to this poll, because I think we all are aware that NAFLD is very frequent in the general population, but to which extent is it so more frequent in obese individuals? That's what I'm looking forward to see what is the opinion. Yes.
Yes, that'll be interesting to see, because do you think that we're seeing more of this because we were more aware of it and we're looking for it, whereas, you know, many years ago, this was not an entity at all?
Well, I think that both are the reasons. I think on one side, of course, we are much more aware and we diagnose it if we diagnose it more frequently. But I'm sure that the impressive increase that has been seen in obesity is a large contributor to this increase in NAFLD, because it really matches very well the increase in the prevalence of obesity. Okay, so I think I already have the results of the poll. May I comment on it, Lilian?
Yes, of course.
Well, you were right. The right answer, at least according to recent studies that I'm going to show next, it is about 65%. So the majority have given the right answer. It is 65%. Of course, we are considering obesity. In general, we are not considering, for example, morbid obesity, because if it was morbid obesity, this prevalence would be much higher. So it is in fact almost 3/4 of the patients that have obesity that will have NAFLD. And so this is in fact a major issue. I see that some of you consider 25%. 25% is just the general prevalence in the population, as you will see next. In fact, if it was morbid obesity, it could be about 90% that should have NAFLD. So, and this is, we are also going to discuss that in the presentation. Also for diabetes, in diabetic patients, we also have very high prevalence of NAFLD, a little bit less than this 65%, but still quite high.
Okay, Helena, I think the audience is ready for your presentation. Let's start.
Okay, so okay, thank you very much. Hello, dear colleagues. It is a great pleasure and honor for me to be presenting on this webinar on obesity, an ongoing pandemic, and to talk with you about obesity and non-alcoholic fatty liver disease. In fact, obesity is a major problem worldwide, and it has tripled the prevalence of obesity worldwide since 1975. And in fact, in 2016, more than 1 billion of 1.9 billion adults were overweight. Of this, 650 million were obese. So 39% of adults were overweight and 13% were obese. So we are facing a major problem. On the other hand, we know that non-alcoholic fatty liver disease is also present in about 25% of the adult population. Of course, areas of the world such as the Middle East or South America have very high percentage of patients with NAFLD, while others such as Africa have much lower prevalences. But what is it in fact NAFLD or non-alcoholic fatty liver disease? It is a spectrum of disease characterized by the presence of steatosis in the absence of harmful alcohol consumption. And we know that about 25% of the normal livers will develop NAFLD, and 20% of those with NAFLD will eventually develop non-alcoholic steatohepatitis or NASH. That is characterized by the presence of hepatocyte ballooning and lobular inflammation, besides the presence of steatosis. And in NASH, we have very different degrees of fibrosis. We have patients with severe degrees of fibrosis and others with less severe degrees of fibrosis. And then 20% of these patients with NASH will develop cirrhosis. And in the meantime, there's always a very significant risk for these patients to develop hepatocellular carcinoma or to develop cardiovascular disease. And this makes them in a very significant risk. What about the relation of NAFLD with obesity? We know that the prevalence of NAFLD in obese is about 65%, while non-obese individuals have only 14% of them have NAFLD. When we look at pediatrics, that is something that's always very worrisome. We know that in obese children with a mean age of 13 years, about 26% will in fact have NAFLD. And that's very much, that's a worry because these are individuals that have still a long way to go and so have a high risk of developing more advanced stages of the fatty liver disease. In fact, when we look the other way around, the prevalence of obesity in NAFLD, we know that 2/3 of the NAFLD patients were obese, according to this meta-analysis of the data from the National Health Examination Survey from 1999 to 2016. And although these 2/3 were obese, that percentage was lower in the individuals that had been born outside the US. And it's interesting to know that, for example, in some ethnic groups like the Hispanic or the Asian individuals, the percentage of non-obese with NAFLD is higher when compared with white or black ethnicity. And this raises the issue of the probable great importance of the genetic factors as a risk factor for developing NAFLD and NASH. In China, we have also seen a parallel increase in the prevalence of NAFLD and obesity. So together with the GDP, we see here the increase of GDP and it parallels NAFLD and it parallels obesity. Also, the same is seen for US, although in a more gradual way than it has been seen in China. But the relation of obesity with non-alcoholic fatty liver disease is different in the different phases of life. Probably in early life, at birth or in early childhood, the genetic factors are much more important, such as, for example, the PNPLA3, that's a risk factor either for obesity or for NAFLD. And also some epigenetic factors, such as high or low weight at birth. Later in life, in early adulthood and in adulthood, it is probably the factors related with lifestyles, such as unhealthy diet with high calorie, high fructose enriched food and Western diet, as well as the low habitual physical activity. And then later in life, it is probably the comorbidities such as diabetes, cardiovascular disease, or osteoarticular disorders that become more important. So it is possible that in the beginning we have insulin resistance, followed by overweight and obesity, then NAFLD with different degrees of severity, and finally, cardiovascular disease and diabetes, although this order can be reversed or be in another way. One of the evidences of this relation of NAFLD with insulin resistance is the prevalence of NAFLD in type 2 diabetes. According to this systemic review and meta-analysis, the global prevalence of NAFLD among type 2 diabetes patients is 55%, what's really very high. Of course, again, it's different according to the different areas of the world, but still, this is a very significant number. And this has important implications for screening, what we can discuss in the end. The link between insulin resistance and NAFLD, the link between NAFLD and diabetes is probably insulin resistance and is also the main risk factor for NAFLD, at least as we now are aware. And the decrease in insulin sensitivity usually precedes the development of NAFLD, although sometimes it is not obvious. Another evidence of the importance of obesity to NASH is that in the patients that are able to lose about 10% of their weight, this is according to this study from Villar Gomez, published some years ago, we can see that after these 52 weeks of lifestyle intervention, if the patient is able to lose 10% of his weight, the probabilities of NASH resolution, fibrosis regression, osteotosis improvement are quite high. The problem is that the patients that achieve this weight loss is really quite low. On the other hand, the patients that lose less than 5% of their weight, the probabilities of NASH resolution, fibrosis regression, and steatosis improvement are much less. So there is a very strong relation. Also, we know that many of the clinical studies that are ongoing, that are on pipeline, and there is a great number of studies, those studies that are also effective on weight loss, such as, for example, the GLP-1 receptor agonists, have been shown to be quite effective in the treatment of NAFLD. And the other very important evidence is regarding the effect of bariatric surgery. According to this study from the group of Philippe Mathurin from La Salle, he has shown that the resolution of NASH associates to a marked weight loss, and also that after 5 years after bariatric surgery, the percentage of individuals that come to have F0 fibrosis increases tremendously. This is just an example of how the histological improvement can be quite impressive. This is baseline. This is after 1 year, where there's always a marked decrease of steatosis. And after 5 years, the histological picture is almost normal. So that's really something very, very impressive. So in summary, I think we may say that NAFLD is strongly associated with obesity. There's evidence that weight gain in hypertriglyceridemia usually precedes NAFLD, and that treatment that are effective in weight loss are usually very effective in the treatment of NASH. But I would not finish without showing you the IFSO policy recommendation, the policy statements. And in fact, what it is stated is that obesity is feeding the rise in non-alcoholic fatty liver disease across Europe. And most of the the policy recommendations, are in the sense of reducing obesity, such as, for example, restricting advertising and marketing to children of sugar and salted beverages and industrially processed foods. And all these measures that aim, in fact, to decrease obesity. So thank you very much, and I'm now willing to discuss with you whatever you think it's useful. Thank you very much.
Thank you, Helena. That's a wonderful start to this session. Thank you very much. I think we'll just keep moving. So Guglielmi, I'll just get you to start the second poll.
Perfect, thank you. Great start, and we'll move to another topic. But before the other topic, there's a very interesting question, and that we would like all of you to answer and to address. And the question is, how is obesity perceived by the population? Wondering if obesity is not a disease, obesity is the main reason for joint disease, obesity is a serious health risk, as serious as cancer, or none of the above. In fact, Raul, which is going to address the topic obesity and cancer, Raul Rosenthal, would you make any comment or any suggestion about this feeling about the population? We know that our UN Secretary General is really concerned with this, hopefully and thankfully, because he understands exactly the impact that obesity has in the world. But what do you think about the population? What is our expectation about what the population thinks about this?
Yeah, thank you, Guillermo. And thank you again, IFSO, for this opportunity to participate. As I was the president of the American Society of Bariatric Surgeons in 2016, I set up a poll because I was curious to understand how is it possible that having a tool like bariatric surgery that is so safe and efficacious, patients do not seek treatment by surgery. My first thought was that it was fear to surgery. Nobody wants to have a procedure done. The second one was the lack of insurance access. What I never thought is that denial was going to be the #1 reason. People don't see themselves as being candidates for surgery or them being the ones who need treatment. Another finding from our poll was to figure out how the population perceived the obesity disease compared to other disease processes. And I won't say stunned, but I was very pleased to see that within that poll, the population perceived that obesity is a serious risk to their health, #1, and #2, as serious as cancer. But still, I felt like there's a way to go to remove that component of denial. So despite them seeing the disease as being a threat to their health, they don't see themselves as being the ones affected by that. And that is probably because obesity has become so common in America, specifically when 60% of the population is overweight. When you look at each other, we all look alike and everyone is smiling, everyone is happy. But this is a silent disease that sooner or later is going to take your life. And while most of us talk all the time about diabetes and sleep apnea and hypertension and cardiovascular disease, cancer is a serious, serious problem. And it is significantly associated to the metabolic syndrome and diabetes, as you will see in a few moments when I present the evidence of what I've been collecting from the literature.
Okay, and now we have the results of the poll. Any comment on these answers?
Not surprised at all that this is what we are perceiving. That's the reason for the denial. They don't see that they are sick. They think that they have a cosmetic problem. I tell you, when patients come to my office seeking surgery and have no comorbidity, which is not unusual in the BMIs of 40 to 50, I tell them, well, a good reason why you're doing this also is to prevent you from having cancer. And they look at me, they say, what do you mean cancer? So you will see in a few when I show the numbers, they are stunning. And that the world is still debating, that we're still fighting with insurance carriers to cover this procedure. It is also not understandable.
Okay, very well. So then, Raul, please enlighten us about this very important topic, obesity and cancer.
Thank you for the opportunity.
Good afternoon. I'd like to thank IFSO and the World Digestive Health Day for the opportunity to present today on this topic, cancer, obesity, and bariatric surgery. In a survey done by the American Society of Metabolic and Bariatric Surgery in 2016, entitled Obesity in America, that was published in SWORD, we found out that 86% of American citizens view obesity as a very high risk to a person's overall health. But what was telling in that survey was that 81% of those who participated felt like obesity was as serious as cancer. It doesn't come as a surprise to know that 640 million people are affected by the obesity disease worldwide, increasing the risk of 13 different types of cancer, many of those related to the gastrointestinal tract. The physiopathology, how obesity triggers cancer, is incompletely understood. It is multifactorial, related to metabolomics, to insulin resistance, steroids, and dysregulated metabolism. There are 67 metabolites that are associated with BMI and breast cancer, as an example. Talking about insulin resistance, we know about the prevalence of diabetes worldwide, which is associated to the obesity disease being the #1 reason for type 2 diabetes. You can see that by 2030, in the United States of America, we'll have 67 million of our citizens affected by the obesity disease, Europe 48 million, Middle East 42 million, Asia Pacific region about 190 million by 2030 that will be affected by the obesity disease and type 2 diabetes. What was telling to me was a paper published by Moore and others in 2014 that observed that there was a 200% increase in the risk of cancer among adults with overweight and elevated blood sugar, compared to 50% increased risk of cancer by adults that were overweight and had a normal glucose. So we are saying that obesity and diabetes result in cancer. Also interesting was what the Centers for Disease and Control Prevention published in 2017, showing that 40% of all cancers in the United States of America were related to obesity. Overweight and obesity was linked to 55% of cancer in women and 24% of cancer in men. That included esophageal, gastric, liver, kidney, and colorectal cancer increased by 30%. Not surprising was Ted Adams' publication looking at the impacts of long-term morbidity after undergoing bariatric surgery, showing that those who lost weight had a decreased mortality by 40%, but 60% of those who died because of cancer. In another study from the Kaiser Permanente group showing a 10-year survey of patients that underwent bariatric surgery or didn't and were obese, what they showed in a very well-matched cohort of 22,000 patients that underwent bariatric surgery compared to 66,000 that did not, that those who had bariatric surgery had a much higher cancer-free survival than those who did not. And this was not only for obesity-associated cancer, also for those who were not associated to obesity. They also looked at the amount of weight loss, if that had an impact in the prevalence of cancer. And what they found out comparing 18,000 bariatric cases versus 40,000 non-bariatric cases in obese subjects, that the more weight you lost, the less the likelihood that you were going to develop cancer. They concluded that patients that had bariatric surgery had a 14% cancer risk reduction for each 10% of weight loss. We can see in many other manuscripts published in the literature the association between obesity, metabolic health, and, for instance, colorectal cancer. 400,000 Korean adults showed a higher incidence of colon cancer if they were obese. The same thing with pancreatic cancer being the third leading cause of cancer death worldwide, showing that bariatric surgery showed durable weight loss and decreased the incidence of pancreatic cancer. In a publication from our group, looking at the NIS patient sample database, we compared a very large population in a period of time of 4 years between obese subjects with and without bariatric surgery. And what we found out was, independently of variables like hypertension, age, gender, and genetic predisposition, when looking at 1.5 million obese subjects without bariatric surgery and compare them those to 250,000 with bariatric surgery, that the likelihood of them developing cancer was significantly decreased if these patients underwent weight loss surgery. The odds ratio was 1.21 for the bariatric case compared to the non-bariatric case. Same thing, the likelihood of developing obesity-related cancer was 25.5% for the bariatric surgery versus 37% for the non-bariatric case, series, showing an odds ratio of 1.7. So what is going on? Why is obesity related to cancer and bariatric surgery seems to have a positive impact in decreasing the incidence of cancer? Well, everything has to do apparently with the length of the chromosomes. The longer the chromosomes and the longer the telomeres, the longer we live. And there's been association between this particular hormonal and genetic effect of bariatric surgery, showing factors that influence other type of cancers like melanoma, pancreatic cancer, et cetera, showing that a change in telomere length after bariatric surgery was significant, lengthening those chromosomes. We see here from molecular genetics and metabolism, similar telomere length increase after weight loss induced by bariatric surgery, 10 years prospective study by Evan Blicher. The take-home message here is that there are similar scenarios and there is a call to action here. The obesity disease is a pandemic. The pandemic carries diabetes, increasing the likelihood of cancer by 200%. Tom Friedman, one of my favorite writers, in one of his last books, Thank You for Being Late, talks about that we're living in special times, the age of acceleration, technological disruption, climate change, nuclear war, and we should be afraid of Mother Nature. But how about obesity? How come they don't mention obesity? Another favorite writer of mine, Noah Yuval Harari, talks about that we're living in times of adaptation, natural selection, intelligent design, and that humans will develop bodies and brains and minds converting into cyborgs. Well, this doesn't look like that. Look at the increased number of obesity in the world, with the United States being the world champ, that it's going to happen by 2030. More than cyborgs, I think the obesity disease is converting us to severely and super obese individuals with a very high risk to metabolic disorders and cancer. In 2012, 56 million people died throughout the world. 600,000 of them died due to human violence. War killed 120,000. Crime, 500,000. 1.5 million died of diabetes. More people are dying from old age than disease. More people are dying from suicide than violence. And more people are dying from obesity than starvation. We can say that while humanity has been able to overcome famine, plague, and wars, obesity has become a pandemic and it's out of control and continues to spread. In 2021, sugar is far more dangerous and life-threatening than gunpowder. We are our own worst enemies. So I'm asking you today to look at bariatric surgery as a source to treat the severe obesity disease, not only to prevent metabolic disorders, but also to decrease the likelihood of cancer. And I thank you for your attention.
Thank you, Raul, for this very impressive presentation. And I hope this really can make some changes in the way as we all look into obesity. Thank you.
Thank you.
Well, let's see if we can make some more changes. We have a third poll before the next speaker, and I'm going to launch the poll right now. So, which of the following cases represent an indication for surgical treatment of type 2 diabetes? Is it type 2 diabetes and BMI of greater than 35 kilograms per square meter? Regardless of the adequacy of glycemic control, is it diabetes and BMI between 30 and 35 if glycemic control is inadequate despite optimal medical management? Or is it type 2 diabetes with body mass index above 27.5 if glycemic control is inadequate despite optimal medical management? So please use the dashboard on the right of your screen to vote. And I'll ask Francesco Rubino, our next speaker, to make a comment about type 2 diabetes and indication for surgical treatment. Francesco, welcome.
Thank you, Lillian. I think today we can say that surgery has become a standard therapy for diabetes. It's recognized by all diabetes organizations and even typical treatment algorithms by the American Diabetes Association and European Diabetes Society are now putting surgery on the map. These are conditions where now surgery is recognized as a therapy, as a standard of care, and it's very important that physicians around the world to become aware of this, because of course these guidelines are relatively recent, and despite major organizations' efforts to circulate and disseminate this knowledge, of course many diabetes care providers are still unaware of the indications to surgical treatment. But surgical treatment is today a reality.
Thank you. Well, I think the attendees might have voted by now. So Francesco, would you like to comment on the response of our attendees?
Well, it's obviously this shows, for instance, maybe people didn't appreciate that for patients of Asian descent, the BMI is now, as a cutoff for indication to surgery, is now lowered to 27.5. People of Asian descent, as many other ethnic groups, have a different association between BMI and diabetes, and these guidelines are the first one to start to understand that link, and so start to change BMI cutoffs for different groups. I think going forward we'll be even seeing this for more groups as the risk of diabetes is at variance quite significantly across ethnic groups.
Okay, on that note, Francesco, let's hear your presentation.
Well, thank you. I'll share my screen. Here we go. And want to thank really very much for the invite. It's a pleasure for me to speak about this subject. The numbers of obesity and diabetes have been already highlighted by the esteemed previous speakers. I just want to focus on the attention on numbers of mortality related to both obesity and diabetes. We're talking about millions of lives lost every year. And if you consider the pandemic of COVID that we're just living in today, and the, of course, the impact it's having. And then you also go back and look at the fact that we have been living with a pandemic of obesity and type 2 diabetes for the past 4 decades without ever being able to flatten the curve of these epidemics. I think this is a major issue that we are dealing with, and we need to definitely be aware that it is an important one to tackle in the next few years. So the other issues that particularly diabetes, on top of obesity, diabetes, type 2 diabetes in particular, is very much associated with obesity, but has a distinct impact on in terms of mortality and morbidity, and it can affect all organs and has a significant mortality linked to its presence. But for many years, this association, epidemiological association between obesity and diabetes has been considered as a result of increased fatness. So too much fat tissue will lead to diabetes because of metabolic links. Now, what I think is happening in reality is that we're learning a lot from surgical interventions on the gastrointestinal tract, which can actually tell us perhaps about a different type of link between obesity and diabetes. In fact, my personal epiphany about this, what surgery could tell us, is this realization that what we call weight loss surgery or bariatric surgery, in reality, is an extraordinary and exquisite treatment for diabetes. In fact, the fact that it leads to rapid resolution of hyperglycemia, but also to lasting remission of the disease, at least as much as we know it for so long, speaks about a powerful effect on diabetes of these operations, maybe even more powerful than the one we see on obesity. So I was really, from the beginning, kind of puzzled by this fact that the resolution of diabetes after this surgery seems to be even more likely to occur than the resolution of obesity itself. And just to give you a sense of this, now more recently I've been looking at, with my fellows, at the last 600 consecutive cases that I operated on. We just made an audit to look at remission of obesity as in BMI less than 30 and remission of diabetes as normal glycemia with no medications. And interestingly enough, you can objectively say that the same procedures induce remission of diabetes in almost 80% of cases, but on much less frequently induce obesity remission. Now, that is not to say that surgery is not effective on obesity. In fact, it's extremely effective on severe obesity. But in terms of dealing with the whole disease and inducing the reversal of it, I think if you accept that these operations on the GI tract are a good treatment for obesity, I think you would agree with me that they're all the more acceptable and actually valuable treatments for diabetes. In fact, if you look at the effect on mortality reduction, when you look at the utilization of these procedures in patients who have obesity but without diabetes at baseline, this is just a recent meta-analysis published in The Lancet, you can see that there is almost a twofold effect in lowering mortality in people with pre-existing diabetes than in people with no diabetes at baseline. And in fact, the number needed to treat to prevent one death is significantly lower in patients with type 2 diabetes at baseline. Again, suggesting that this is operations on the GI tract are excellent for obesity, it may be even more so for diabetes. So GI surgery is an exquisite treatment for type 2 diabetes. And to me, that observation speaks about a different relationship between obesity and diabetes. The question that raises is it the fat, the missing link between obesity and diabetes, or is the gut? In fact, over the last many years, we have found that the gastrointestinal physiology is crucial for glucose metabolism. And surgical operations on the GI tract can alter each and every of those mechanisms of physiology, suggesting, of course, that the reason why diabetes is improved is not just because we decrease fatness, but because of the metabolic effects that we're doing. And this is now pretty much recognized. We now also have a substantial clinical evidence from level 1 clinical evidence, indeed, that surgery is superior to any other form of diabetes therapy, as shown by dozens of randomized clinical trials that have been published so far. So this is quite a conclusive, I would say, level of evidence. And in fact, this has been recognized by many organizations. These are the Diabetes Surgery Summit global guidelines. They're now endorsed by over 50 organizations and even by health insurers from Korea to Switzerland to now France, Brazil, and also private insurers now in the United States are recognizing the new guidelines that, as we say in the question, do suggest and recommend that surgery is considered in patients with diabetes, especially if it's poorly controlled with medications, even though their BMI might be as low as 30 or maybe 27.5 for patients of Asian descent. But one question that I think also surgery allows to answer is this idea of whether or not diabetes is a curable disease. And I think that our recent study published in The Lancet just a couple of months ago may allow us to address this question indeed. So this is a randomized trial. This is a 10-year follow-up of a randomized trial comparing surgery and medical therapy. And this is the only long-term 10-year follow-up of a randomized trial of this type so far. And this is a study that compared 2 operations by gastric bypass BPD versus medical therapy. And I want to point out that this study had an extraordinarily high retention rate at 95% at 10 years. So it's quite remarkable. We had inclusion criteria that made us recruit only patients with severe advanced diabetes. And remission of diabetes was the primary endpoint, but we also looked at various secondary endpoints pre-specified, including diabetes-related complications. The study showed that, as predictable, perhaps surgery far achieves that remission of diabetes and prolonged remission of diabetes over 10 years, whereas this is not possible by medical therapy and lifestyle interventions. Overall, there was a better glycemic control in patients who had surgery, regardless of remission. A1C levels were decreasing from baseline in surgical patients far more than in medical patients, which also the study has demonstrated thanks to good new drugs available in the market. We had an overall improvement of diabetes in the medical arm from 10 years before, which is remarkable. Nevertheless, this is not yet as close, nearly close to what surgery can do for diabetes. Surgery also resulted in better quality of life. Both operations had better quality of life results than medical therapy. And very importantly, we found that diabetes-related complications occurred far more often and significantly so in people who had medical therapies compared to surgical interventions. Also, surgery resulted in less use of medications of all sorts, particularly no requirement for insulin, even though at the beginning of the study, at least 50% of patients in the study had a need for insulin therapy, and also non-diabetes medications of all sorts, including all the ones used for cardiovascular disease, were statistically significantly reduced by surgery compared to medical therapy. So this is a very important finding in terms also of the perspective of cost effectiveness. So the American Diabetes Association, with a consensus statement some years ago, defined that diabetes remission persisting for more than 5 years as an operational cure, operationally as a cure of diabetes. And now I would suggest that this is not something that we see rarely with surgery. This is a typical patient of mine who had diabetes, had an operation, and goes on for 10 years seeing no sign whatsoever of diabetes clinically and in the laboratory. And this is our randomized study has shown happens quite substantially in more than a third of patients at 10 years. So you have, I would argue, at least a third of patients that could be potentially cured from even advanced diabetes. Again, not early diabetes, as all the patients in this study. So perhaps because of all this evidence, the Lancet has recognized on the cover page that metabolic surgery is more effective than conventional medical therapy in both short and long-term control of type 2 diabetes. But I want to conclude my presentation by highlighting a big problem we have is that despite all this evidence, despite this dramatic evidence and also this potential of curing diabetes and reducing mortality, etc., less than 0.1% than the 1% of people around the world who meet the criteria for surgery actually have access to surgery. And in many countries, this figure is actually 1.2. So what are the barriers? There are misperceptions around surgery, misconceptions around the use of surgery, and also stigma that play a role. I just want to conclude by giving you two ideas of what could be in the way of understanding and accepting surgery. If you ask healthcare providers, as we did in a congress here in London, which of the various conditions that we proposed to them could be resolved entirely by just changing lifestyle, then type 1 diabetes, cancer, osteoarthritis, people recognize that they are not resolvable just with lifestyle changes. But when it comes to both severe obesity and type 2 diabetes, still too many healthcare providers believe it's so easy to treat them as just changing your lifestyle. And in fact, in a major survey of 5,000 people in 4 countries, we asked the question, what is the most effective treatment of severe obesity or type 2 diabetes? And you can see that 80% of responders say the lifestyle intervention is the most effective treatment, despite of the fact that there is no evidence for this. So the lack of awareness, lack of knowledge about the severity of the disease, there's a misconception of the reversibility of the disease by just deciding to reverse it, is perhaps one of the barriers that comes into the way. And finally, I want to highlight the role of stigma as a major barrier. This is a study, this is just an observation we made using a study that measures stigma across various countries. And then we looked at volume of bariatric metabolic surgery in the same countries that all share a sort of national healthcare system. And you can see that in red, increasing level of stigma are associated with decreasing volumes of surgical operations per year, suggesting that in fact stigma is a major driver for the low uptake of surgery, despite now the evidence is clear. And I want to just finish with this slide because I think it's quite emblematic that a journal as conservative, a medical journal as The Lancet, certainly not a surgical journal, not very enthusiastic about surgery historically, has now believed that the evidence is so striking to put this statement, this conclusion on their cover. So surgery is more effective than any therapy we have for type 2 diabetes. Thank you.
Absolutely fascinating. Thank you, Francesco. Well, we've had 3 very good presentations. We're going to start inviting our panelists to give some comments. I'm going to start asking Lauren Beato. Lauren, you are a surgeon in Canada, and do you see in your practice increasingly number of your patients presenting with bariatric surgery, with non-alcoholic liver disease and cancers?
Yeah, increasingly so, and it's an ongoing problem. It's really emphasized the lack of awareness. Just yesterday, a 55-year-old lady with type 2 diabetes referred for bariatric surgery, and at the time of surgery, we found cirrhosis, not only NAFLD or steatohepatitis, but she had a full micronodular liver cirrhosis. So this lady could have been referred 10 years ago, and we could have prevented this evolution. So that's very common. And also in terms of cancer, yes, well, that's a good occasion when we see the patient for pre-op to check for screening, because those are very common if we look for them: colon cancer, breast cancers, and also some GI tract cancers.
Yes, we also have some of our panelists to make some comments and eventually guide through some questions to our presenters. And I would like to ask Dr. Nicola Di Lorenzo how much he was impressed with this overwhelming evidence of effect of surgery in terms of controlling a well, lots of sort of metabolic diseases, and especially tackling cancer. Dr. Nicola.
Dan, I'm sorry, I was keeping the microphone off. Sorry, I will start my talk. As Dr. Rosenthal has well depicted, the connection with cancer is so important that we cannot deny the situation. The fact is that recently papers are also presenting, 2 days ago, one was published report from Oregon, saying that colon cancer is increased after bariatric surgery. So I think we should continue to study in the scientific world concerning especially the microbiota and so on, because maybe there is something that we don't understand well about data on our patients operated. But I still continue to say that we need to increase the awareness of people about the risk of cancer in our overweight patients and obese patients. And this is a battle which is going on in all our countries. It's not an easy issue, but I think this is the focus and the reason also for pushing occasions like this is that we need to continue to increase the awareness of people about the risk of coming with obesity.
Yeah, I also would like to call in Dr. Saeed Hamid. We all care about liver within this topic. And the fact is that Elena presented many evidence of how obesity affects liver, but at this time, you think it's appropriate to, and that is one of the questions that was put up by our audience, is it a time to change the name? And is that only a semantic issue, or is it much more than that, changing NAFLD to metabolic associated liver disease?
Thank you, Guilherme. I strongly believe that changing the name does not probably affect the patients that much. What we haven't been able to convey is how bad is a fatty liver disease to you in the end. People don't understand that this is now the biggest reason for liver transplantation in many parts of the world. It is rapidly becoming the biggest reason for liver cancer in many parts of the world. Now that we are treating hepatitis C and controlling hepatitis B. So I think it's more the awareness, the creating of awareness, and the fact that this could be prevented by many means, as we've heard, rather than changing a name. Yes, changing a name might be more useful in the scientific quarters, but I don't think it's going to affect the patients. Patients come to us to say, oh, doctor, I've got fat in my liver. What do I do? What is the risk? Those who are concerned. So that's point number one. I just wanted to make one other point or a couple of points. And one is that South Asia in particular, as you know, is now the hotbed for diabetes. 25% of our population is either diabetic or pre-diabetics. And most of them have truncal obesity, and they're going to run into trouble very, very soon and in great numbers. We've already heard the numbers, 190 million people in one of the presentations. The other point that I think we need to elaborate on and perhaps discuss is the fact that in patients with non-alcoholic fatty liver disease, we are seeing liver cancers without the presence of liver cirrhosis. So we are not going through the sequence that we are so well aware of as treating physicians of cirrhosis and then cancer and so on for hepatitis B and C. So that's scary because nobody knows how to screen these people. We very well know how to screen hepatitis B and C patients for our liver cancers. There are good algorithms there, but we really don't know how to screen these patients and when to screen these patients who have fatty liver disease for liver cancer. And none of our liver societies are yet recommending any sort of screening for these patients. So those are just a couple of points that I would like to put on the table and perhaps have a discussion around to see what the learned audience and the speakers have to say about that. Thank you.
Yeah, you're absolutely correct about the non-proven usefulness of any screening program towards liver cancer in obese patients. Further along the road, do we have a direct correlation between obesity and the amount of steatosis in the liver, which is another big issue? Because how can we be sure? Can we measure? Can we assess that? Should we rely on liver biopsies finally and again? What do you think about that?
I think we've lost the battle for liver biopsies because it's very difficult to convince people now to get biopsies. And so our next best option is to look at fibroscans and shear wave elastographies and so on, which are helpful. But obviously, being hepatologists, we've grown up with liver biopsies, and that is what we would want to do. And perhaps that is something which may need to come back for at least for fatty liver disease, if not for viral hepatitis, and we don't need that anymore. So my suggestion is we should revive the art of liver biopsy.
Right. We still have some questions from the audience, and one is also very interesting. There are lots of questions, but one of them is directly connected to the second presentation about the need, or how can we be sure that when we undergo bariatric surgery and we perform partial gastrectomies, how can we clear for sure precancerous lesions to exclude bias on eliminating early gastric cancer? Can we do that? Are we doing that regularly every time? And that was a question posed to Dr. Raul Rosenthal.
We can't hear you, Raul.
Yes, you need to. We cannot hear him. I'm not hearing the answer, and I was wondering if any of our panelists would make any comment on this issue. Yeah.
I'd be happy to comment. Yeah, there was some new guidelines that just came out a few months ago from both IFSO and ASMBS commenting on this issue. And yes, we are going more and more to a preoperative upper GI endoscopy in any patient who have GERD symptoms or who have some upper GI symptoms. And also, but this is a lower level of recommendation for patients who have bariatric surgery. It can be also recommended to have an upper GI endoscopy and to repeat this type of endoscopy every 5 years, 3 to 5 years in every patient who had bariatric surgery, because of some studies showing up to 20%, 25% of Barrett's esophagus. But in terms of esophageal cancer and gastric cancers, these are really case reports. So out of the hundreds of thousands of bariatric surgeries that are being done every year, we have only a few case reports of upper GI cancer. So it's very reassuring, but we have to follow pre-op and post-op for Barrett's.
Correct. There's also one
if
very
I can add a single word, coming from the European, Raul is coming back. I don't know if you can.
Yeah, I'm driving to the OR.
Our European.
Okay, then
I was just commenting about the fact that the European guidelines were published last year together with the European chapter. Were still stricter about the fact of having an endoscopy on most patients, or even all patients going for bariatric surgery because of the reasons you mentioned before. So it's a trend because we want to prevent things, and to control the patients after the surgery is important as well.
Interestingly, we have two very provocative questions, and I'm still not sure who is going to take this to answer. But anyway, let's see. One question: diabetes is so common. What are the clinical criteria that we have for progressing to surgery in diabetes? Should we go? When should we go? When should we propose surgery for diabetic patients? What are the numbers?
I think this is a very good question, because the guidelines that I just mentioned say that based on current evidence, patients who have certain characteristics should be all considered for surgery. But even if you buy into those guidelines, you would have millions of potential candidates for surgery, so well beyond the potential capacity of any surgical departments around the world. So the problem is how we select patients and prioritize patients with diabetes to surgery. Earlier this year, we published in the Lancet journal a consensus statement to guide and recommend how to prioritize patients. And what we said is that even in the context of surgery for diabetes, where there are many patients can benefit, there are some patients who can benefit more. So there are patients, for instance, who are on insulin, patients who have already developed cardiovascular disease. For them, the likelihood of the number of patients needed to treat to save one life is plausibly much lower, and I think those patients should be prioritized. The problem is that today, none of these patients are prioritized. Generally, a patient who presents to their doctor with diabetes is 99% of the time not informed that surgery is an option at all, and I think that's something that needs to be changed.
Correct. And Elena, we have a very interesting, another provocative question about why is the hepatologist's guidelines do not recommend surgery for obese NAFLD or NASH like diabetologists? Why are liver people conservative?
Well, in what regards the American guidelines, in fact, they do not recommend. I think it's because there were rather few studies demonstrating, well, the effect on patients with NAFLD, besides the effect resulting from the weight loss. However, the European guidelines, the last European guidelines that are already from 2016, already recommend that well-selected patients should be considered for bariatric surgery. So I think there is a trend, and I think probably after this study that I mentioned of Lassaï, of the group of Philippe Mathurin, with these impressive results on the resolution of NASH attaining about 84%, I think at least in the European guidelines, I think it's very possible that the next guidelines will already consider at least that in patient, well, because also you have to be aware that guidelines say that patients that have indications pursued for bariatric surgery should undergo. The issue is to do the bariatric surgery just for the treatment of NAFLD NASH. And for that situation, I think that probably in the very short future, it's possible that it's going to enter the guidelines.
Yeah. And endoscopy will come around.
There's also some fear always of the side effects.
Right.
Perfect. Of the morbidity and.
Lilian, would you make any question or any comments on this discussion we're having?
Yeah. I'm just reading the questions. There's many interesting questions coming in. One again on hepatic steatosis. Helena, the question is the degree of obesity correlated with the degree or the extent of hepatic steatosis?
Well, I'm not aware of any study that really correlated exactly the degree of obesity to the degree of steatosis. But the issue that I would like to mention, and it was already discussed previously with Professor Ahmed, is that the amount of steatosis is not What is more important for us when we are evaluating a patient with non-alcoholic fatty liver disease? It is much more the degree of fibrosis or the necroinflammation that's present than the degree of steatosis. And in fact, that's the reason why what I think it's really important to measure, as it was mentioned, was the degree of fibrosis by FibroScan or other methodology that measures fibrosis, because that will make the difference between those patients that will progress to end-stage liver disease, or at least to fibrotic forms of NASH, more than the degree of fibrosis per se. And in fact, we have some patients with like 80% steatosis on their livers, but don't have a really important necroinflammation or important fibrosis. So I think we have to focus, and in fact, that has been the focus much more on the degree of fibrosis.
Okay, that's another question to Raul Rosenthal about cancers. Is there a particular cancer that is most prevalent in the obese population?
Yes, I would say the most concerning one is breast cancer. 55%, as I mentioned in the presentation, of cancer in women are linked to the obesity disease, and the most concerning one is breast cancer. However, we have to say that when it comes to GI disease processes, I would be very concerned about gastroesophageal reflux disease, obesity, Barrett's esophagus, and esophageal cancer. I think we are seeing a research of adenocarcinoma of the distal esophagus because of obesity-related reflux and adipose reflux that triggers Barrett's esophagus, dysplasia, and cancer. But definitely breast cancer is number one, and as I mentioned in the presentation also, 30% increased risk of colon cancer.
Okay. Now, there's another interesting question. We know that obesity is related to hepatic steatosis, NASH, and diabetes. But why is the resolution of NASH or diabetes independent of weight loss?
Well, let me take that question. I think the idea that weight loss should be the reason why things improve is also misconceived, because weight loss is not a mechanism, it's not a physiologic mechanism. Weight loss is the consequence of physiologic changes. So pretty much like changes in glycemia, so it's weight loss, a change that occurs because of other mechanisms. But anyway, because we conceived weight loss as a mechanism for all those things, we and others have done studies to understand the weight-independent effect of surgery on diabetes, which I think now is quite consolidated as an evidence. But more recently, we also seen with Geltrude Mingrone and colleagues and myself in rodents that also the effect of surgery on NASH is weight-independent. And we are at the moment conducting a clinical study here in London to verify this findings in humans. The reason why this might be is because NASH, pretty much like diabetes, has a pathophysiologic background that includes insulin resistance, as well as other hormonal inflammatory mechanisms, all of which have been already shown to be affected by gastrointestinal surgery. So if surgery is weight-independently improving diabetes, the chances, the odds are very high that it will weight-independently improve NASH.
While we've got you, Francesco, someone wants to know what kind of policy and regulations would you like to implement to tackle obesity?
Well, I personally think that we need to make the picture much less blurry than it is. When we say obesity is a disease, which I do agree, for some patients it is a disease. We, however, use a blanket definition that until we define obesity in a better way, in a more clinically meaningful way, is actually like a boomerang, is kind of create a pushback against us. Because many people say, if you say obesity is a disease, then everybody with BMI over 30 has a disability, has an illness. And maybe that's not true here and now. they might have it later on, but not here and now. But nevertheless, some people have a disease here and now. So with the Lancet journal, we just are, this is confidential, but I'll share with the world today. With the Lancet journal, we are starting a Lancet commission to define clinical obesity as an entity with more clinically meaningful criteria than BMI. And so the definition of clinical obesity might not meet the definition of obesity, the condition based on BMI. So that's perhaps what I would like to see in the future. A more clinically meaningful definition that allows us to treat where we need to treat and prevent where we need to prevent. They are not the same things.
Can I add something on? Well, I would say it more on the perspective of early prevention. And I think that countries have to think of taxation measures, taxation for the price of sugar beverages, of some kind of food. Also, I think it's very, very important to have a focus on children and on all the marketing policies, a very big difference. And in fact, in Portugal, we had some years ago, we included a taxation for sugar and salted beverages, and that resulted in a marked decrease in the consumption. We don't have yet the result in health or in the degree of obesity, but just the fact that the consumption decreases, I think it's very, very important. And also campaigns such as that one of drinking water, having water available on places. Of course, I think that bariatric surgery is important, but it's like the end of this spectrum. So I think that we have much earlier in life, try to change the way people think and the way people eat. And of course, also policies for the building of the cities to have more availability for spaces to walk, for the children to play. I think these are very, very important policy, but the governments have to be very well aware of that and do what's needed to change it. Otherwise, it will always be getting worse.
Yeah. If I can add a comment, Guilherme,
yep.
May I?
Sure.
Yeah. To Francesco's point, does everyone with a BMI greater than 30 consider him or herself as disabled? I don't think that every disease we suffer from necessarily will be disabling. But I think the answer is yes, because even if you are not disabled, the obesity disease keeps working while silent, while not hurting. And the development of NASH, the development of cancer, the development of cardiovascular disease, it takes time. And while the patient might be very happy and enjoying the large meals and a sedentary lifestyle, despite being obese, at some point, the alarm will sound. And by that time, there is so much that has been harmed that it's going to be very difficult to reverse with any kind of intervention. So the answer to the world is keep your BMI under 30, because otherwise, sooner than later, you will get in trouble. And in my answer is yes, obesity is a disease.
Yeah. Okay, I agree. And the fact is that that is a very important message, especially for everyone concerned with digestive oncology, which has been creating a momentum with obesity. It's clear that GERD and the complications of GERD, long-run complications of GERD, are clearly related with cancer. But in many other organs, we've seen liver, pancreas, and of course colorectal cancer. But you know, when Elena was talking about the importance of other measures, a question came up, and well, and in fact, it's still important to consider this, especially when we think globally, as our societies try to do. And that the question was, is there still a place for lifestyle interventions in primary care and in the community? How can we address that?
Maybe I can take
the answer is the answer is absolutely yes.
Yes.
We should not advocate that the first line of treatment of any disease process should be going to an operating room. So I think the ambulatory lifestyle interventions, counseling, surgery should be last on the list. The big question is when to intervene, and that is something that we don't have the formula at this point. Thank you.
May I add to that question, because I think it's a perfect question to meet with what Raul was saying about disease, non-disease. When you use lifestyle interventions, you would do so either for other diseases, either as a complement to therapy, so treatment, or as a preventative measure in patients who still do not have a disease. So yes, the question is lifestyle interventions should be implemented globally to prevent severe obesity, to prevent diabetes, and sometimes to complement treatments. The problem we have is that lifestyle interventions used as a treatment of disease is a misconception, because when you have a disease, then it's past the point of lifestyle intervention. You need a medical intervention. Now, back to Raul's question about disease, not disease. The fact of having a condition of risk for future cancer, diabetes, or NASH, or everything you want, doesn't constitute evidence for disease here and now. Disease entities are normally categorized because of a number of other factors. And so what I'm saying is that, yes, obesity can be a disease, but if we measure with the wrong metrics, we are actually overdiagnosing the problem in some, and we're underdiagnosing the clinical entity in others. That's why we need a better definition than the WHO current BMI-based definition. Otherwise, we're not going to move on from this impasse.
Thank you. Lillian?
One more question on cancer, Raul, from the audience. They want to know if the specific type of bariatric surgery, is there one better than the other as a benefit for longer survival or prevention of cancers?
There is no evidence in the literature, level 1 evidence, that can support the one procedure versus the other. I think we see under the umbrella of weight loss so much good happening that I would say any procedure, any intervention that can help you not only lose your weight but keep the weight down should be considered as a treatment modality. But if it is going to be the BPD or the bypass or the sleeve, that depends on the patient, on the disease, on the BMI, on the comorbidities. There are so many factors that are going to affect which surgery to choose. But any of those will result in weight loss, and I think that's where we see the positive effects of bariatric surgery.
All right, I think that's a very good note to wrap up this session. It's been a very interesting and fascinating talks and discussion from everyone. So I'd like to thank all the speakers and the panelists for their time and their contribution. It's a great start to the World Health Digestive Day, and I look forward to the next session. So thank you, everyone.
Thank you, bye.
Hello, everyone, and welcome back to our second session. We had a great first session, and we hope to continue. I'm going to start by introducing my co-moderator, Professor Lillian Cao, who you've heard speak and moderate in the first session. She's the current president of IFSO and the senior past president of IFSO Asia Pacific chapter, and the senior past president of the Obesity Surgical Society of Australia and New Zealand. She's a senior consultant at the Flinders Medical Centre and clinical associate professor at the University of South Australia. And she's obviously been involved in training multiple surgeons in bariatric surgery, both nationally and internationally. And I'm so glad to have her here as my co-moderator and co-director of the day.
Thank you, Reem. It is a pleasure. And hello, everyone, and welcome to session 2 of the World Health Digestive Day 2021. It is my privilege to co-moderate this session with Reem. She's the Associate Professor of Medicine at Weill Cornell Medical College and attending physician at the New York Presbyterian Hospital at the Weill Cornell Medical Center. She's also the Director of International Endoscopy with board certifications in gastroenterology and internal medicine in both the United States and the United Kingdom. So it's also my pleasure to welcome our esteemed panelists who have kindly joined us for this interesting session. Firstly, I'd like to welcome Samar Mata from the USA. He's a professor of surgery at Baylor College of Medicine, where he's also the chief of division of metabolic and bariatric surgery. He's the past president of the American Society of Metabolic and Bariatric Surgeons and past president of the Fellowship Council. Welcome, Samar. Next, I'd like to welcome Gerhard Prager from Austria. He's the professor at the Division of General Surgery at the Vienna Medical University in Austria. He's the former president of the Austrian Society for Obesity Surgery, and he's the current president of the European chapter of IFSO. Warm welcome to you, Gerhard. Next, I'd like to introduce Eamon Quigley from the USA, who's the chief of the Division of Gastroenterology and Hepatology at Houston Methodist Hospital, Texas. He's the past president of the American College of Gastroenterology and the World Gastroenterology Organization. Welcome.
Hello, everybody.
Last but not least, I'd like to welcome Kazu Kasama from Japan. He's the director of the Weight Loss and Metabolic Surgery Center at Yatsusa Medical Cube in Tokyo. He's a clinical professor of Oita University in the School of Medicine in the Department of Surgery, and he's the current president of the Asia Pacific chapter of IFSO and the immediate past president of APMBSS. Welcome, Kazu.
Thank you for having me here.
And thank you. And now I'm going to introduce the speakers for this session. We have Dr. Ken Lowe, who's a specialist upper gastrointestinal surgeon with an appointment at St. George's Public and Private Hospital, the Carina Private and Sutherland Public Hospital. He's performed over 3,000 surgeries and advanced laparoscopic surgeries, including primary and revisional bariatric operations. And currently he holds the position as an honorary treasurer of the Obesity Surgery Society of Australia and New Zealand, and is the secretary of IFSO Asian Pacific chapter. Thank you and welcome.
Thank you.
We welcome Dr. Caetano Marcassini. He is from Brazil and has been involved in endoscopy and laparoscopic surgery for many years. He brought the intragastric balloon to Brazil in 1999, and in 2017, he performed an endoscopic sleeve gastroplasty. He's currently active in the area of general surgery and dedicated his time to obesity. Welcome. And following this, we have Professor Christopher Thompson, who is Director of Endoscopy at the Brigham and Women's Hospital, co-director of the Center for Weight Loss Management and Wellness. He's a Director of Advanced Endoscopy Fellowship Program as professor at the Harvard Medical School in Boston. We also have Professor Manuel Romero Gomez from the University of Seville in Spain. He's the chief of the digestive diseases at the Virgen del Rocío University Hospital and the head of the group for translational liver and research in the Institute of Biomedicine of Seville and Spanish Network. He's the leader of sub-project 7 for the European project Liver and Digestive, leader of the Litmus project. And he's the coordinator of the European NAFLD registry funded by IFSO. And finally, last but not least, we have Dr. Silvia Lete Ferreira, who is the vice chair of IFSO Integrated Health Committee. She holds a PhD and master's in human nutrition, and she's committed to broadening her investigative work in the field of nutrition related to bariatric surgery. She's a member of the ASMBS, IFSO, Bariatric Brazilian and Metabolic Society, and American Dietitians Association. So welcome. And Ken, if you can launch your first case, thank you.
Welcome to the first case study. My name is Ken Loy. I work in Sydney, St. George Hospital, and I'm a GI and bariatric surgeon. And I'm also current executive treasurer for IFSO APC. I have no conflict of interest regarding of this talk, and I speak for Veris's company as well. The first case today we have is Mrs. J.M., who's 50 years old lady, morbidly obese, BMI 51, weight 122 kilo, height 1.52 meters. She had various comorbidity, metabolic problem, including hypertension, high cholesterol, and she also type 2 diabetes, but also on insulin as well, and had diabetic history of more than 10 years. She also had reflux and a small hiatus hernia on gastroscopy, other disease including sleep apnea and arthritis and polycystic ovary syndrome. She was referred to public bariatric program, and based on decisions by our committee with MDT, we decided to perform Roux-en-Y gastric bypass plus repair hiatus hernia if possible. She lost some weight when we started pre-operative fast for about 2-3 weeks, and her operative weight at the time was 115 kilo. Her blood test before showed iron deficiency anemia with hemoglobin of 110. Her creatinine is normal, 81. Her vitamin B12 is also quite low before surgery. Her liver function test showed mildly deranged AST, ALT, and albumin 34 as well. Her other liver panels, including hepatitis B and C, are negative. We performed preoperative ultrasound, which showed fatty liver with fibrotic changes, and subsequently performed FibroScan, which showed early fibrous changes. Just a word of reminding how we're going to measure it, which could be explained by our gastroenterology colleague in the panel. That I think FibroScan, the fibrosis score is regarding of how much pressure in the liver is measuring, and she's roughly around FibroScan of about 2 to 3. Operation-wise, she had a Roux-en-Y gastric bypass, and due to metabolic problem, we decided to do a long BP limb and a short Roux limb, which bypassed total of 1.6 meter of small bowel. Intraoperative finding, as picture has indicated, show fatty liver with some early cirrhotic changes despite operative fast, but some weight loss enabled us to perform the surgery. She has difficulty with intubations as well, and also there was a difficult dissection with hiatus due to the space constraint and intra-abdominal access. The left lobe of the liver was quite solid and was difficult to retract with the nascences, which obscure some of the view of the hiatus. Nonetheless, we managed to perform hiatus hernia repair and the bypass successfully. There was some oozing from staple line. The stomach seems to be quite thick as well, but it was stopped by oversewing and also the buttressing as well with seam guard. Wedge liver biopsy performed for diagnostic purpose and comparison for the future as well. Her operations, the postoperative, in fact, was quite unremarkable, and she was discharged in day 4. And on 6-week follow-up, she already showed improvement in her liver function test, and she already lost some weight down to about 105 kilo. She's off oral diabetic medication and still on some insulin as well. And her wedge liver biopsy shows significant fatty liver with some early cirrhotic changes. So 6 months follow-up, her liver function test is nearly normalized, and her weight down to about 88 kilo, and repeat liver ultrasound show marked improvement of liver steatosis, and so as the results of the repeat fibrous scan as well. So I guess the question will be open to the panel in terms of our esteemed gastroenterologist colleagues regarding of what sort of investigation if we encounter these cases with fatty liver, and what sort of follow-up, probably more traditional, such as digestive, and also a surgical colleague in terms of whether there is any role of different type of operations applied to this case, and also a nutritionist, and see if 2 weeks of walk-active fast is enough or not, and also our physicians as well in terms of managing the comorbidity. I'll open this discussion to the panel, and hopefully we can have some insight regarding of how to manage this type of patients. Thank you very much.
Thank you, Ken. And I'm now going to hand over to Lillian to launch the poll.
All right, we have a poll for the attendees. If you could use the dashboard on the right of your screen to answer this poll question, which operation do you think is the best for the treatment of fatty liver disease? There are 5 options here. We'll ask you to choose. While the audience is making up their minds of which is the best treatment, Ken, what is your operation of choice for fatty liver disease?
Look, I think whatever I'm speaking is probably not going to be right. I would defer the answer to my esteemed colleague, but I guess giving the experience from the last sessions, I think it's really opened our eyes when we are collecting our data regarding of obesity as a disease, comparing to COVID even, because COVID disease is only hopefully short term, but this is a ongoing things that is going to consume ourselves. And I think it doesn't matter about operation like Rahul say. I think the most important things is when to operate and how we're going to operate without causing long-term or short-term problem. I suspect traditionally Roux-en-Y gastric bypass is what we're trying to do for metabolic disease, but a lot of the other surgical options has opened up the doors on potentially more powerful interventions, according to my surgical colleague. But I guess with power come responsibility, and I think there will be more nutritional issue that we may encounter as well. So I guess that's why we are here for. So I'd rather listen to our expert instead.
All right, before we do that, let's see what the attendees say. Have we got the answers to the poll? We should have any moment now the answers.
Before the answer, I guess I have to throw in a little bit of our Asian Pacific things. I think as you've seen, there's going to be a lot of patients that we have to deal with. And I think we got to plan for the futures. And our criteria, according to Kasama's and all of us looking at our Asian, is slightly different than Caucasians, but we can draw on their experience and see what happened.
Well, looking at the poll, 45% of the attendees believe that the Roux-en-Y gastric bypass is the best treatment for fatty liver disease. So I think we will ask the opinion from our speakers. So I'm going to start off by asking the bariatric surgeon to tell us about this presentation. So I'm going to invite Professor Citano Marcassini for his presentation and his comments.
Yes. Hello, guys. I have a presentation recorded, but the thing is about when doing the surgery, this is a good question. And what surgery depends on basically on what the liver looks like during the surgery, and the biopsy and the pre-op exams will show us. So I think we can show my recording lecture, please. Could we start?
Hello, guys. My name is Caetano Marquezini. I'm a Brazilian surgeon and been doing bariatric surgery for the last 27 years. These are my disclosures. I guarantee any of them will interfere in my lecture. Well, first things first. This is angulation, something I've been doing for the last 20 years. And this 45 angle position modifies consistently the fat and visceral arrangement inside the abdomen, improves the visual angle of the optics, and shortens the distance between the trocar entrance and the camera and the hiatus. Liver retractors are very important during the laparoscopic procedures and usually requires an additional trocar and subxiphoid incision, increasing risk of wound complications and postoperative pain. And the use of traditional mechanical liver retractors had been associated with transient increase in liver transaminases and risk of iatrogenic liver injury. And there are a lot of proposals published. I advise a lot of surgeons to take a look at these papers. In patients undergoing surgery, the prevalence of NAFLD is 62%. 1/3 of these patients already have fibrosis. 9 to 20% will progress to cirrhosis. Cirrhosis will be diagnosed incidentally in 4% of surgeries. Bariatric surgery impacts on NAFLD in 88% of improvement and leads to 30% of improvement in fibrosis. Gold standard diagnosis is liver biopsy, which is important to calculate an NAFLD activity score. And interestingly, there was no statistical difference in improvement after sleeve gastrectomy and Roux-en-Y gastric bypass. But we do know that surgeons usually favor sleeve gastrectomy over Roux-en-Y gastric bypass. And this is because there's a potential risk of hepatic decompensation after malabsorptive procedures. It difficults the access of the bypass stomach and bile duct, and the altered anatomy with Roux-en-Y gastric bypass may make future liver transplantation more difficult. The biggest hindrance to preoperative counseling of patients about the risk of the surgery is that the majority of cases of cirrhosis are diagnosed incidentally during the surgery by visual inspection of a nodular liver. Routine intraoperative liver biopsy should be offered to all patients undergoing surgery. Liver stiffness measurement can be reliably and predict the presence of advanced fibrosis preoperatively with a sensitivity of 80% and specificity of 85%. Early postoperative liver decompensation may happen in 7% of the patients, which should be managed conservatively. And Roux-en-Y gastric bypass should not be a contraindication, being reserved for situations where sleeve gastrectomy is not possible as Barrett's esophagus or severe GERD. In cirrhotic patients, portal hypertension is a relative contraindication of the surgery. And the surgery may ameliorate comorbidities as type 2 diabetes, hypertension, dyslipidemia, but will probably not show any improvement in cirrhotic liver fibrosis. In these patients with a compensating disease, the mortality is 0.9%, but it can increase to 17% in patients with decompensated cirrhosis. There's a limited data on outcomes on bariatric surgery in cirrhotic patients, but in cases with advanced liver disease and severe portal hypertension, it has been advised to do the TIPS procedure prior to the surgery. And finally, patients with ultrasound-proven steatosis and ALT level above 53 should undergo intraoperative liver biopsy because there's a high probability of NASH. Thank you very much. These are my considerations, and I will be here for you guys to discuss and talk about what I have stated. Thank you very much.
Thank you, Caetano. I think we'll move on. I'm going to invite Chris Thompson to give his views as an endoscopist. Thank you, Chris.
I'm Dr. Christopher Thompson from Boston, and I've been asked to speak on the treatment of NAFLD and NASH from the endoscopic perspective. Here are my disclosures. To refresh our memories, fibrosis stage is the strongest predictor of liver-related outcomes, The mainstay of treatment of NASH is weight loss, with 7% total weight loss being associated with improvement of steatosis and inflammation, and 10% total weight loss required for regression of fibrosis. So the main questions that need to be answered are, can EBMTs achieve a 7 to 10% total weight loss, and is there any evidence for improvement in liver inflammation or fibrosis with these procedures? EBMTs can be broadly classified into two categories: gastric devices such as balloons, suturing platforms, and aspiration therapy, which primarily focus on weight loss, and small bowel devices such as sleeves and duodenal and mucosal resurfacing, and anastomotic devices, which have more direct metabolic effects. We will start with intragastric balloons, and there's several types. There are fluid-filled balloons, there's gas-filled balloons, there's adjustable balloons, and procedureless balloons as well. They all have fairly similar weight loss outcomes, so we'll focus on fluid-filled balloons in a meta-analysis of 17 studies in over 1,600 patients that showed a total weight loss of 11% at 12 months. This is really across all relevant BMIs. This was a case report from our group looking at a 29-year-old female with Down syndrome and various serious medical conditions. She was 181 pounds, 4 foot 10 inches tall, and a BMI of 37.8 with NASH. And the initial liver biopsy is seen here with grade 2 steatohepatitis and stage 1 fibrosis. She underwent a 6-month balloon placement, and at removal, her weight was now 110 pounds with a percent total weight loss of 39.2 and a BMI of 23. And EUS guided liver biopsy performed at the time of balloon removal is seen here with a complete resolution of steatohepatitis and no significant fibrosis. You also have a prospective series of 21 patients looking at early stage liver fibrosis and intragastric balloon treatment. You can see at 6 months when the balloon was removed, there was a 11.7% total weight loss. And here are all of our liver outcomes. There's a 3-point median decrease in NAS. Fibrosis improved by 1.17 stages. MRE detected fibrosis improved by 1.5 stages. And it was a quite encouraging study. However, percent total body weight loss did not seem to correlate with a reduction in NAS or fibrosis. Moving on to gastric remodeling and endoscopic sleeve gastroplasty. And you can see here we're trying to really recreate a gastric imbrication procedure endoluminally with a series of running and interrupted stitches. So here's a meta-analysis looking at 8 studies in over 1,700 patients, which shows a 16.5% total weight loss in 1 year and a 2.2% adverse event rate. What about metabolic outcomes? We have a prospective registry from Reem Sharaya's group looking at 118 patients, and they all underwent ESG for NAFLD. Main outcomes here are hepatic steatosis index and NAFLD fibrosis score. In 2 years, we have a 15.5% total weight loss. And you can see the HSI score decreased by 4 points per year, and the NAFLD fibrosis score decreased by 0.3 points per year. So very encouraging. And here we have 24 patients showing an improvement in risk of hepatic fibrosis, decrease from an F3-4 or indeterminate down to a F0, F2, and only 1% of patients experiencing an increase in that risk. Duodenal and mucosal resurfacing also shows some promising results in a multi-center single-arm study of 47 patients, which showed improvement in HbA1c, fasting blood glucose, ALT, and AST, but very interestingly, they showed a 30% lowering of relative fat and a 6% reduction of absolute fat on MR hepatic fat. And finally, we have a meta-analysis looking at all EBMTs and their effect on metabolic comorbidities. 18 studies, over 800 patients, 14.5% total weight loss at 6 months. And you can see here the primary outcome is liver fibrosis, 4 studies, 162 patients. And the fibrosis was reduced. Here you see the standard mean difference by 0.7. And the secondary outcomes, including ALT and histologic NAFLD activity score, were all significantly improved as well, although the grade was low to very low for quality of evidence. In conclusion, EBMTs do achieve 7 to 10% total weight loss, and early evidence suggests that they may offer a promising alternative for the treatment of NAFLD and NASH. And I believe combination therapies and personalized treatment programs are now the keys to future success. Thank you.
Thank you, Chris. I think we'll move on. We'll hear from the hepatologists I'm going to invite Dr. Manuel Gomez to give his comments. Thank you, Manuel.
Hello, everybody. It's a great pleasure for me to be part of this World Digestive Health Day, and thank Professor Macedo for inviting me to this very interesting panel. Today we are discussing the case by Professor Loy, and I'm giving my opinion as a hepatologist in this patient with morbid obesity and NAFLD. This is my disclosures. And our female, in summary, Mrs. J.M. is female, 50 years old with comorbidities, including diabetes, arterial hypertension, hyperlipidemia, sleep apnea, and because with morbid obesity, 53 kilo per meter square as body mass index. That means morbid obesity. Our patient showed a quiet fibroscan with 249 decibelius per meter in the cap. That means in the limit of steatosis, but in the ultrasonography, you can see how the liver is hyperechogenic in comparison with the kidney. And on the other side, fibroscan was 6.8 kilopascal. That means it's a quite relaxed fibroscan, usually associated with non-advanced fibrosis because lower than 8 kilopascal. But it was a surprise when we calculate the epimetriosis score and was 0.84. That means highly risk of advanced fibrosis, and FIB4 was 3.19, also linked to advanced fibrosis. Is Mrs. J.M. suffering from an NAFLD-associated advanced fibrosis with this fibroscan and this non-invasive method? I think so. In this study by Professor Ampuero, demonstrate how the interpretation of the kilopascal of the fibroscan depends on the metabolic alteration in the liver. When the epimetriosis score is higher than 0.47, a fibroscan lower than 14.3 kilopascals or a fibroscan higher than 6.2 kilopascal demonstrate a risk of that significant fibrosis in approximately 3/4 of the patient, advanced fibrosis F3, F4 in a half of them, and cirrhosis in 8 to 10%. That means our patient seems to be at risk of advanced fibrosis. And please, surgeon, do not forget a liver biopsy during the surgery if doing bariatric surgery. We need to keep in mind what can we do in this patient with NAFLD at risk of advanced fibrosis and morbid obesity. The key point is try to promote weight loss. If our patient lose 10% of the body weight, we can improve steatosis 100%, promote fibrosis regression 80%, and NAS resolution 90%. That means that in the 10% of patients undergoing this lifestyle intervention, we achieve a weight loss of 10%. That means 90% fail to reach this goal. This is the main reason by which we need to move from the diet and physical activity to the use of drugs. In the drugs, we can use semaglutide, naltrexone, bupropion, or orlistat. This drug able to promote weight loss when we analyze what is happening in the liver in the second liver biopsy at 24, 36, 48, or 52 weeks, irrespectively of lifestyle intervention versus, for example, orlistat. The improvement in the NAS score, steatosis, ballooning, and lobular inflammation was comparable and quite similar. Semaglutide is a GLP-1 agonist able to promote improvement in the liver. In this clinical trial published in New England last year, semaglutide in the high dose demonstrated that NAS resolution in 60% of the patient is a very high rate, but also the semaglutide high dose was linked to body weight reduction of 12.5%. That means we can be absolutely confident that this drug is able to promote weight loss, and this weight loss was associated with improvement in the liver, in steatohepatitis resolution, and also with the rest of the parameters. Just in our patient, we should confirm advanced fibrosis in every patient. We need to implement lifestyle intervention. It doesn't work drug therapy. It doesn't work endoscopy and bariatric surgery, because we need to promote weight loss. Semaglutide therapy emerged as a first-line therapy to promote weight loss in patients with NAFLD at risk of advanced fibrosis. This is my part, and now the patient require more advanced therapy, including endoscopy and bariatric surgery. Thank you for your attention. Many thanks to my team in Virgen del Rocío University Hospital, the Department of Disease, and also the Celiber Group in the Institute of Biomedicine of Seville. Thank you very much for your attention.
Thank you very much. And I'd like to now welcome Sylvia to talk about the nutritional aspect of this case.
I would like to thank IFSO and WGO for the invitation. I'm glad to be here, and I'm going to make some comments about Dr. Kinloy's presentation about a patient with non-alcoholic fatty liver disease. I have nothing to disclose. And as we know, non-alcoholic fatty liver disease is the most prevalent form of chronic liver disease in the world. It affects near 15 to 35% of global population, and it is more prevalent among patients seeking bariatric surgery. We also know that a modest weight loss, near 5 to 10%, is known to decrease intra and postoperative complications, such as hypertensive crisis, diabetes, thromboembolism, sleep apnea, and principally hepatomegaly. And we know that decreasing the liver size, it may contribute to a reduction of surgery time. This chart we can see, it is a randomized trial conducted by our team, and we saw that patients that had presented weight loss before surgery, they presented also a reduction in surgery time. So when we talk about weight loss before surgery, most of the time we use a very low calorie diet that is an energy restriction that goes up to 800 calories per day. Dr. Kinloy used an OptiFast, that is a commercial brand of a liquid, very low calorie diet. We know that these diets, when they are used in an adequate way, with an adequate amount of protein, carbohydrates, vitamins, and minerals, they will have patients to present a rapid weight loss. They will decrease visceral fat, they will present reduction of liver size, and they will keep their vital healing capacity with just few side effects. Dr. Kim and his team used this diet for 2 weeks, and the patient presented a good weight loss, near 5%. She presented the 2 nutritional deficiencies. They were treated before surgery. Despite the good weight loss that the patient presented before surgery, during the surgery, they saw that she had enlarged liver. And it happened probably due to the advanced stage of cirrhosis that she presented. However, with 6 months, the patient presented a good amount of weight loss. She had lost 27 kilograms, and she has shown an improvement in the degree of fibrosis, showing that the non-alcoholic fatty liver disease was treated with the adequate amount of weight loss that she presented after surgery. And some recent guidelines, they have shown that even when the patient presents some histological manifestations of liver injury, they can take advantage from the bariatric surgery, and they can get better from their fibrosis with the weight loss, using bariatric surgery as a tool for weight loss. I would like to highlight 3 important points as a conclusion. First, that there was a concern about weight loss before surgery. Dr. Loy's patient present the BMI higher than 50, this population, they need to lose a little bit of weight because it will contribute to the decrease of surgery time. So it is important to highlight that losing weight before surgery is an important treatment. Second, there was a concern about nutritional screening. There was this concern and the patient was treated. And it is important to highlight that this population, they present at least one nutritional deficiency before surgery. So I was happy that Dr. Kinloy and his team had this treatment before surgery. And third, that bariatric surgery is, and in this case was effective in treating non-alcoholic fatty liver disease. Thank you.
Thank you very much, Dr. Sylvia Ferreira. And now, before we start our discussion with our esteemed panel and speakers, we'd like to relaunch the poll that you heard at the beginning of session 2. Many of our audience members have changed their mind. So the question was, which operation do you think is the best for the treatment of fatty liver disease? And the answers are sleeve gastrectomy, Roux-en-Y gastric bypass, single anastomosis gastric bypass, single anastomosis duodenal bypass, and the endoscopic sleeve gastroplasty. Just to be controversial, Samer, I might ask you as the first question while we're waiting for the poll to launch and answer. Do you think there's any one right answer in this, or is it just weight loss?
Well, the right answer is to do what's right for the patient, obviously. So you need to study your patient carefully, know what their comorbidities are, and whatever other conditions they might have. I was a little surprised, and this is no criticism of my friend, Dr. Loy, but in a patient who has a history of anemia and who has arthritis, who might be requiring NSAIDs, who knows, might be smoking, I would favor a sleeve gastrectomy, especially in patients who have liver disease, because there's always the possibility that they may need a liver transplant in the future, and you want to maintain that endoscopic access to their biliary system. But the only right answer I can say is to do what's right for that particular patient.
I agree. I feel like a lot of patients come in with the preconceived idea of what they want, and here are the answers. Do you want to comment on these, sort of the before and after?
So we can see here a small shift of respondents from gastric bypass towards the sleeve. I think maybe based on understanding the progression of fatty liver disease and that it could lead to liver failure or liver transplant. And some of these patients are very ill, especially if they're very heavy. So I can see the sleeve gastrectomy as an operation that might result in resolution of comorbidities that are equivalent to a large degree with Roux-en-Y gastric bypass. That's what I see here. And it's interesting that also Dr. Thompson's lecture has influenced the respondents. As you can see, there's been a rise in the number of respondents advocating endoscopic therapy.
Perhaps I can sort of echo on Samai. I agree. It was actually a really struggle on which operation we decide to do and tossing around all the risk factors. But yeah, we don't have the crystal ball. We try to do what the best for the patients, and essentially weight loss will be the best. But procedure-wise, it is hard to choose. And I think there'll be a different answer for if we ask everyone, I think.
Absolutely.
Reem, Lillian, can I ask a question?
Definitely.
Yeah, absolutely.
Sure. I just, first of all, my disclosure is that I'm not a hepatologist and I'm not directly involved in obesity, but I'm very honored to be here. But just listening to the wonderful case that was presented, I had a couple of questions. Based on our previous session when we spoke about cancer and the fact that this patient had iron deficiency anemia, preoperatively, I just wondered if consideration was given to upper endoscopy and perhaps colonoscopy before proceeding to surgery because of the risks. And the other question I had is in terms of the liver disease, how far you would go in terms of assessing for portal hypertension, given that you were also going to perform anti-reflux surgery, and whether, for example, you would do endoscopy looking for varices.
I think we did do gastroscopy, and colonoscopy has been excluded in terms of colon cancer, etc. And I guess partly to assess for the reflux and Barrett's and hiatus hernia, and that's why we decided also to repair it, because there are studies that pointed out even despite Roux-en-Y gastric bypass seems to be the treatment for reflux surgery, you still have to attend to hiatus if possible. And the liver disease do increase the difficulties of accessing the hiatus due to space constraint, but we managed to repair that, and the reflux was moderately or markedly better together with the weight loss as well. I guess I shouldn't speak, I think I speak too much, and I should leave some of the space for my esteemed panel to comment on that.
I'd like to ask a question to our other surgeon in the panel. Gerhard Prager, what is your preferred operation?
I think there is no deep preferred operation. I think all these operations that lead to markedly weight loss will also improve NAFLD. NASH improvement is, of course, much more difficult to achieve. But I just want to mention a word of caution. If we exclude larger amounts of small bowel, there might be, let's call it, too much of a good thing. I give an example. When we had a look at our one anastomosis gastric bypass series, excluding at least 1.5 meter, we see in the first year an transient elevation of liver enzymes, which comes after 1 year to normal. But if you go further and exclude even more, you see also, or you can see, a deterioration of the liver function. This means we should be cautious to exclude bigger amounts of small bowel in patients with advanced stages of fibrosis. Saying that, I fully agree that sleeve gastrectomy and Roux-en-Y gastric bypass with a rather short BP limb are the procedures of choice in patients with advanced liver fibrosis. For those with even cirrhosis, I just want to mention that doing a sleeve gastrectomy, you change the portal blood flow, and this might contribute to an elevated percentage of portal vein thrombosis in patients with sleeve gastrectomy, just to give you a little bit food for the brain.
And to add to that, Dr. Quigley's question, if we get referred patients who have an established diagnosis of cirrhosis, then we typically do look for portal hypertension, because that is a very high risk factor. Patients can essentially exsanguinate on the table. So we do a CT scan, or we do interventional radiology will help us out. And if they do have portal hypertension, then we might apply tips, a shunt, to try and reduce their overall mean gradient. This has its own side effects, of course. These are a very high risk category of patients that we treat very carefully and optimize very carefully before considering surgery. But after all, surgery is their only resort, because that's the only way they're going to get a liver transplantation.
I just want to mention that it is very difficult to identify preoperatively those patients with very advanced NASH. FibroScan in our hands was not especially successful in the morbidly obese patients, although we were using the X-large probe. So this is still something we are struggling with, at least in our institution.
I agree.
One thing we do in our institution is a very thorough GI evaluation, obviously even for the surgical patients, but Something that's very useful is endoscopic ultrasound to look at the liver, but then also to do liver biopsies and direct portal pressure measurements. It's minimally invasive, and it's really a great way to assess risk in these patients.
Yes, to add a comment, I would like to highlight that in cirrhotic patient or in patient with NASH and advanced fibrosis, the main aim, the goal is to lose 10% of body weight. That means we need to be conservative when selecting the method to achieve this goal, and we don't need to lose many kilos. No? And it could be very important because we can balance both the risk and the benefit when managing this patient, in which I looking from the liver, no, as a liver-centric point of view. I'm just concerned about that. And just adding a comment to a previous discussion about how can we consider obesity, no, if a disease or a symptom. From my point of view, obesity is just a condition. It's like alcoholism, and this is the key point we need to address. Thinking separately, we have two problems: obesity and the liver disease, and separately we need to address it in different manners.
So if I may, I have a question I've been meaning to ask you, Dr. Gomez. I agree that reaching 10% weight loss is very beneficial for these patients. It reverses a lot of the problems of the liver. The problem is, though, maintaining that weight loss. You know, I have yet to see a paper that has a long-term effect of lifestyle. And medications work, like your GLP-1 agonists, but they're expensive, and the patient would have to take them for the rest of their lives. As for endoscopy too, many of the procedures tend to be temporary, whether it's balloons or sleeves. And so, you know, what are we left with that has a long-term beneficial effect? And frankly, I am biased because I'm a surgeon, but I think the truth is that for now, surgery is the most effective long-term therapy for these patients.
I fully agree. This is the most difficult challenge at this time. How can we address that? Because regain is very common. More than a half of patients in very short period of time, at 5 years, is very common. This is an option to promote endoscopy or bariatric surgery, because the patient need some help beyond the lifestyle intervention, even beyond the drugs. But we need to try to develop a multidisciplinary approach, trying to have, for example, to have the liver recovery in the hospital, as we can recover the heart of the kidney or the lung. I think we need to work together with nutritionists for sure, with the surgeon, hepatologists, and all of us trying to improve the health of the people. That for sure it's strongly related with weight loss, but we need to promote weight loss and to keep. And just a major problem that I think we have in clinical practice now is the management of obesity pre-transplant patient. Cirrhotic patient with morbid obesity that require the liver transplantation. What are we doing? And at this time, we can start a therapy in a very short period of time, 3 to 6 months. For example, a patient with liver function okay and a liver cancer, we can try to promote weight loss in 3 to 6 months. But for sure, we need to keep in mind that after the transplant, we need to keep the patient in this weight, and this,
or else they lose their transplant.
For sure, this is the same problem that we need to address. Is how are we prolonging over the time all our activity to keep the patient safe and healthy.
If I may interject something here. So I think it's risk and benefit, right? We heard that with gastric bypass and advanced liver disease, you have substantial risks there. I agree with balloons. I mean, there's lower risk, but if there's no benefit, it's also not worth doing it, right? So ESG, however, does have very solid data for 5-year outcomes and maintaining a 15% total weight loss. So that's great. And now if you combine, and Dr. Sharaya's data is really one of the best there. Now, if you combine that with medicines, we might be able to really get a long runway with this while minimizing risk. So I think that we should not say surgery is the only answer here. I think we have to look at endoscopy as a very good solution for many of these patients because it allows us to limit risk and does get us stably above that 10%, but it's not balloons or necessarily some of the other therapies. The other thing that is interesting is duodenal mucosal resurfacing. Now, this gets back to something Francesco Rubino was talking about. We do not see 10% total weight loss with that at all, not remotely, right? But they were getting really impressive results with reversal of liver fibrosis and fat improvement. So something very interesting there is another mechanism of action unrelated to weight loss. So I think we have a lot of learning to do. And I do think there's, surgery is certainly a wonderful option for many of these patients. But I do think we also have to be very open-minded about these endoscopic alternatives.
Great. If I may just make an intervention here, it's important to notice that liver disease is not the only thing that occurs in these patients. These are very obese patients. They usually have diabetes. They usually have hypertension. They usually have a lot of other diseases that I'm an endoscopist. I really believe it's a new method and it's coming for something different in the future. But for now, for these patients that there are a complex unity of diseases, I still think surgery is the best solution for these patients because we can see not improvement only in liver fibrosis, but in the rest of the comorbidities.
Yeah, I think we may not agree on the answer here, or we would just have a long, lengthy debate, but I'm glad and the risks and benefits of each type of procedure. Sylvia, there's a question to you from the audience. What do you comment on the keto diet for obesity and for diabetes? And if you suggest the keto diet, how long do you suggest patients to be on it?
As a strategy for preoperative weight loss, we used to use more very low calorie diets. That's Dr. Kim used, OptiFast, that has a right content of carbohydrates, protein, and lipids. Keto diet can be used in general population like obesity. My concern is with the adherence of a keto diet for a long term. So maybe for 3 to 6 months, it can be a strategy. Or if you have a patient that is losing weight and you need to change the strategy, sometimes keto diet should be a strategy. However, as it doesn't have a lot of carbohydrates or nothing of carbohydrates, the adherence is a challenge. So maybe listen to your patient, and knowing the adherence and the weight loss is a good way to know if it is going to be effective.
Thank you. And do you recommend the OptiFast diet for everyone pre-op, or is this something that you would also recommend for people sort of after surgery they've had, or after endoscopy, they've had a little bit of weight gain in order to maintain their weight loss?
OptiFast is a commercial brand of a liquid diet. And I have studied a liquid diet before surgery, and it's a good strategy if you use like from 2 to 12 weeks. However, 12 weeks I think is like too long. 2 weeks is enough because most of the weight patients lose in the first 2 weeks. And the adherence is better than when they eat normal food because there is less options, and it is easier to measure a cup of whey protein or a plate of a soup. And when you use a brand such as OptiFast or whatever, you know the content it is easy to know the content of the food. So I think it is a good strategy when you want rapid weight loss and with a security like before surgery, you need to improve the nutritional issues. You should promote good wound healing. So I think it is a good strategy. Here in Brazil, we don't have this brand available, but we have other brands. And you can do a liquid diet even with real food like soups, whey protein, and yogurts, things like that.
I have a question for Kazu. If in the Asian population, we know that obesity, lower rate of obesity is associated with the comorbidities of the metabolic disorders. Do you find that fatty liver disease is also more prevalent at a lower BMI in the Asian population?
Yes, that's true. So from the viewpoint of Asian Pacific chapter, I'd like to emphasize that NASH, the biopsy-proven NASH, is much higher in Asian population. Like my series of biopsy, 74% of my patients BMI over 35 had NASH. Also in Taiwan, 72% of the patient, the bariatric patient, had NASH. But in Australia, just around 30 to 40% of the bariatric patient have NASH proven by biopsy. So that the Asian population has much higher risk of NAFLD. And recently, Asian Pacific Association of the Study of Liver Diseases just published their clinical guideline for NASH. They tried to change the name from NAFLD to MAFLD, metabolic disorder associated liver diseases. So that, and also they made a guideline to indicate the bariatric surgery for BMI over 35 with NASH, with MAFLD. And also for Asian population, BMI over 30 with MAFLD should be considered bariatric surgery. So that in the Asian Pacific region, the view is a little bit changing now. And also that the important thing is the follow-up of the Ken Lloyd's patient, because I also have the same kind of patient, and he lose more than 35 kilogram, and also all kind of comorbidity resolved. And also the CT scan revealed that NASH and the NAFLD had a resolution at 2 years after surgery. But he developed HCC at 7 years after surgery, because the patient still have some fibrosis after surgery. So that such kind of patient must have some kind of follow-up, like sonography every year or something like that. That's my point of view.
Thank you. From the attendees, there's a question for Chris Thompson. Is there any experience about combining intragastric balloons and ESG for better weight control?
Yeah, not so far. That would be a sequential thing that would have to be done. We know that balloons are contraindicated in any stomach that has had any type of surgery, whether it's anti-reflux surgery, prior bariatric surgery, et cetera. So it's important not to do them, in close proximity. And I would probably say you would start with a balloon and then sequentially follow that with an ESG in planning a study. But I'm not aware of any data using that approach yet. More likely, you're going to see combinations of ESG with a small bowel procedure, such as an ESG with mucosal resurfacing or ESG with a endobarrier type device or maybe a magnetic anastomosis. Or medications, right? Semaglutide, that'd be a really great combination that Vivek Kambari had studied a little bit with some Brazilian colleagues that seemed very compelling.
So I think with the diagnosis of a fatty liver or NASH or NAFLD, liver biopsies is still considered the gold standard. But as surgeons, we don't always do a liver biopsy. I like the opinion of the other surgeons. Do they do liver biopsies regularly or only when they're asked by the hepatologist or the gastroenterologist?
Yeah, this is Samer. And in the early phases of my career, I used to routinely do liver biopsies on all our patients. In fact, all my partners did as well. And then we found that the information that we had from these biopsies really didn't inform us in the course of the patient or its prognosis. So we stopped doing them unless it was indicated or in specially selected patients. But now that I'm, my interest in this disease is rising again, I think I will go back to routinely doing liver biopsies. It takes only, you use the true cut needle, it takes only 5 minutes. And although it's not a totally benign procedure, it is rather safe as long as you do it properly. So the answer is, I'm going to go back to doing routine liver biopsies, yes.
How about you, Gerhard Prager?
I do it routinely in all my patients, I think, for the last 10 years. And I find it very useful.
Citano?
Well, here we have to, talk to the insurance payers about what we are going to do prior to surgery. So we have to justify the motive. So no, we don't do it routinely. But when I get any visual intraoperative modification of the liver, I do the biopsy because I cannot get out without getting the diagnosis I need. So then I justify what I'm doing to the payers. This is the only problem. And some exams we do, and a lot of things we are talking about preoperatively. I know there's a lot of countries that the insurance payers, they do not pay for these exams. They do not, they require a lot of paper doing, and usually they do not let us to do these exams, including endoscopy. Chris, I know here in Brazil we do it routinely, but I know there's a lot of countries that it's not justifiable for the payer. So this is important also to talk to who's listening to us, that we have to go for what we have on our hands.
Lydia, just a comment?
Yes, definitely.
I'm more than happy listening that you are doing or planning to do routinely, because as we learn from the biochemistry, that ALT-HT, normal ALT-HT is very common in patients with NAFLD, and we need to use non-invasive tests like FIB4, etc. When you are looking at the surface of the liver, it's much better to have a liver biopsy, because many times you can find a future that you are not can anticipate when you are doing the surgery, and I think it's very important to stratify and to quantify exactly what is happening in the liver to improve the management of this patient. And at this time, liver biopsy is crucial because, as we discussed before, non-invasive tests like FibroScan, the XL probe, they are not enough diagnosis accuracy for the decision making, and we need to combine. For sure, we need to develop an algorithm, a diagnostic algorithm, to be absolutely confident with the stage of fibrosis and the presence of steatohepatitis. But in the meantime, we need to use the liver biopsy of gold standard, and surgery is a fantastic moment to have this information.
What about Japan, Kazu? Do you do liver biopsies?
I used to do a liver biopsy in a clinical study setting, but recently I don't. Actually, that it's very rare to have a chance of a second biopsy for the patient after bariatric surgery, so that we couldn't reveal that the improvement of liver disease by second biopsy. But yeah, as many here suggest that it's very useful to do a routine biopsy, so that we will talk with our colleague to do that.
Okay. Reem, have you got any other questions to ask our panel?
No, I was going to ask the same thing to Chris, if he routinely does either FibroScan or liver biopsies, or we're more increasingly doing so because of the availability of portal hypertension testing now endoscopically.
Yes, we'll do a FibroScan on all patients, revisions or primaries, and then depending on what we see on the FibroScan, we will do an endoscopic ultrasound with liver biopsy and portal pressure measurements. And I think it's very nice to do. We don't do that as part of the actual weight loss procedure. We do that in advance. That way we're catching some people with portal hypertension, and we can address that with beta blockers and proper preparation before our procedure.
If I may mention something, please. One thing I'd like to suggest or even recommend to the group and other clinicians is what we've done here at our institution in Baylor. We've actually started a fatty liver clinic. And it's a clinic where patients who have fatty liver disease, many of them are obese. We approach them in a multidisciplinary fashion with the hepatologist. We actually have designed a special educational seminar for these patients. And we work together to both evaluate, optimize, and then treat these patients. And the beauty of it is that they continue to be followed in this specialized clinic. And with the rising number of these cases, I think there's a lot of benefit in that, but just a suggestion for the group.
I totally agree.
We do the same thing. I think that's sort of the future, are these multidisciplinary clinics between all prongs of what we see here in the case presentation, all disciplines to be part of it.
Hello, everyone, and welcome back to our session 2. We are going to launch our second case presentation. So this case will be presented by Dr. Abdulrahman Nimari from the USA. He's the Associate Professor and Chief of Bariatric Surgery of the Carolinas Medical Center. He's the Secretary and Treasurer of IFSO and founding President of the Middle East and North African chapter of IFSO. So welcome, Abdulrahman. Following the case presentation, we will also have comments from, firstly, Dr. Estuardo Behrens from Guatemala. He's the past president of the Guatemalan Association of Surgery. He's the past president of the Guatemalan Society for Bariatric and Metabolic Surgery, and the current president of the Latin American chapter of IFSO. Welcome, Estuardo.
Thank you for having me.
We welcome. Next, we have Dr. Bahram Abudaya from the USA. He's the Associate Professor of Medicine, Director of Advanced Endoscopy, Director of Metabolic and Bariatric Endoscopy at the Mayo Clinic in Rochester. He's the recipient of multiple awards and grants in support of his research, including the Star of Science Award awarded to him by His Majesty King Abdullah II during the World Science Forum in the Dead Sea in Jordan 2017. It's a pleasure to have you, Bahram. Next, we have Dr. Shelby Sullivan from the USA. She's the Director and Gastroenterology Metabolic and Bariatric Program at the University of Colorado at the School of Medicine. Welcome, Shelby. Last but not least, we have Dr. Mary O'Kane from the United Kingdom. She's a dietitian and she's the chair of the IFSO Integrated Health Committee. Mary led the development of the British Obesity Metabolic Surgery Society BOMS and the nutritional guidelines for the UK for the follow-up guidelines for patients undergoing bariatric surgery. Welcome, Mary. I'll now invite my co-moderator, Reem, to launch the poll.
Hello, everyone, and thank you, Lillian. So we're going to launch the second poll for this session. How do you evaluate a patient with GERD dysphagia and class 1 obesity and type 2 diabetes? First, an endoscopy and upper GI barium study, endoscopy and esophageal manometry, upper GI barium study and CT scan of the abdomen, history and physical examination is sufficient, or finally, evaluation by a bariatric surgeon. Please vote using the dashboard on the right of your screen. So while we're waiting for the attendees to answer, I'd like to ask Abdul Rahman to comment on this poll and what you think.
Sure, thank you, Reem, and I want to thank IFSO and WGO for the invitation. I think what's important to note about reflux is that the disease is a disease where symptoms don't necessarily correlate with objective findings. So when someone has heartburn, you might want to do an endoscopic evaluation, and if it shows significant reflux like Barrett's or LAC or D esophagitis, maybe those patients, you don't need to do anything else. But especially in patients who are considering to have procedures like sleeve gastrectomy in our field, someone has reflux symptoms and they just have not much on the endoscopy or grade A esophagitis, they might need real objective testing, maybe with a pH study. And the second important thing is, when someone says they have dysphagia, I mean, that is just a very broad term, and you need to really dig deep into that term and make sure whether this dysphagia is something recent, whether it's to liquids or solids, and maybe start first with just getting an X-ray test.
Okay, and we have the results. Would you care to comment a little bit on the results before we start the case presentation?
Sure. I think I'm very pleased to see that evaluation by a bariatric surgeon is not the first thing for this patient, or that history and physical is sufficient, because truly, or getting a CAT scan. I think the audience is right on the money, and I think both options have an endoscopy, which is reasonable. Getting a barium study first, or proceeding right away from manometry
will depend on the symptoms and dysphagia, and both of them are appropriate answers. So I think the audience is on the money.
Okay, well, thank you. And I'm going to invite Dr. Abdulrahman Nimari to present his case.
Good morning. It is my pleasure and privilege to participate in the combined World GI Organization and International Federation for Surgery of Obesity webinar. My name is Abdulrahman Nimari. I am an associate professor and section chief of bariatric surgery at Atrium Health, and have the privilege of and pleasure of being the IFSO secretary treasurer. It is my honor today to be with you to present a case about reflux, class 1 obesity, and type 2 diabetes. This is my disclosure slide. It has no bearing on the presentation. You can see my procedure disclosure as well as financial disclosure at the top. So our patient, GRD, is a very pleasant 43-year-old female who's been having significant reflux. She also lately had dysphagia. She's had reflux for 10 years, daily heartburn, regurgitation, and cough at night. She takes PPIs and lately noticed dysphagia to solids. She's tried numerous times to lose weight, and whenever she loses weight, her reflux improves, but then she would regain the weight back. She has class 1 obesity, BMI 34 kilogram per meter squared. She's been diabetic for 7 years on insulin, as well as metformin and glipizide. Her latest A1C is 9.5%, and her diabetes has not been well controlled. High blood pressure on 2 medications and hyperlipidemia on a statin. She smokes a pack per day for the past 15 years and would quit off and on, and her examination is largely unremarkable. Her endoscopy shows, as the picture depicts, a 3-centimeter hiatal hernia, grade B esophagitis without Barrett's, and she was H. pylori positive. She had a 48-hour Bravo capsule study that showed that on both days she has at least 125 episodes of reflux. The percent of the time where the pH was low was 8% on the first day, 12% on the second day, mostly in the supine position. She has a Demeester score of 48. Her manometry showed no motility disorders and the presence of a hiatal hernia. The patient is interested in a management strategy that minimizes the risk while addresses her reflux, dysphagia, her weight issue, as well as her diabetes. She's motivated to make a change, and she's more concerned about not only reflux, but the fact that her diabetes is uncontrolled, as she was told this could affect her quality of life. The patient is most interested in endoscopic options. She heard about a procedure called Stretta. She wants to hear more about it, as well as laparoscopic options that have lower risk. So she's heard about a procedure called Lynx. She also wants to hear about it. When it comes to other procedures, she wants to know if having a fundoplication would help her reflux and if that's the best procedure for her. And she's very concerned about the options of metabolic and bariatric surgery, especially Roux-en-Y gastric bypass, as she heard many complications with that surgical option. If there is any surgery that would help her weight, her consideration would be to have a sleeve gastrectomy. Again, I would like to thank the World GI Organization and IFSO for the opportunity to participate in this webinar. Thank you.
Thank you, Abdulrahman. A very interesting case. I'm going to invite our first speaker as a surgeon to comment on your case, Dr. Estuardo Behrens.
Good afternoon, good morning, good evening. My name is Estuardo Behrens, and I am the actual president of Latin American chapter of IFSO. Thank you for the invitation to participate in this webinar of the World Gastroenterology Organization, together with the International Federation of Societies of Obesity Surgery. Dr. Nimari has presented us a very interesting case. These are my disclosures. I have nothing to disclose. I do not have any conflict of interest. My case makes disclosure. In the last 21 years, I'm doing bariatric and metabolic surgery, 3,841 cases in the last 21 years. This is a very interesting case of a young female patient, 43 years old, who has a metabolic syndrome, florid metabolic syndrome, with obesity class 1, type 2 diabetes treated with insulin and 2 drugs, hypertension with 2 drugs, and hyperlipidemia with statins. A very heavy smoker patient, 20 cigarettes per day. And she's complaining of an important gastroesophageal reflux disease and hiatal hernia. The patient wants a relief. She's very well motivated to have a new life. The workup performed in this patient showed us that an upper GI endoscopy, she has a very important hiatal hernia, 30 centimeters wide. Achalasia was ruled out, no motility disorder, and H5 pylori positive in this case. What are the alternatives? Well, we have to discuss this very well with the patient because she has a relief of the esophageal reflux, of the diabetes, hypertension, and the other comorbidities. The best alternative in this case is a Roux-en-Y gastric bypass plus closure of the hiatal hernia. If we perform a sleeve gastrectomy, the patient is going to have more reflux. We will discuss that later. The Stretta procedure is non-recommendable because it does not give any weight loss. The LINX is not recommendable because the patient is going to have only a poor weight loss. And the gastric mesenfulmoplication is a very well performed procedure in this kind of patients with GERD, but the type 2 diabetes and the other comorbidities had to continue in medical treatment, and it shows only poor weight loss. So the best alternative in this case must be a Roux-en-Y gastric bypass, laparoscopically performed with a closure of hiatal hernia. You can see in the picture a wide hiatal hernia, and in the picture on the right, you can see the closure of the hiatal hernia. And this is the end result. You can see the gastroduodenostomy performed, and this is going to relieve the reflux. We're going to close the hernia. The patient is going to have a very good weight loss, and the type 2 diabetes and hypertension, hyperlipidemia are going to remit and control. So the patient is going to have a very quality of life. So the best alternative, as I said, is the Roux-en-Y gastric bypass. All the time we have to think first in our patients. So the principle of primum non nocere, first do not harm, must prevail. The sleeve gastrectomy is going to produce more gastroesophageal reflux disease, albeit the control of the metabolic syndrome, and in the near future, the patient has to have a Roux-en-Y gastric bypass. She's going to be converted. The endoscopic procedures are not going to control the metabolic syndrome, so they're not useful in this kind of patient. The fundoplication will control the GERD, but not the metabolic syndrome. So in these cases, we have to discuss with the patient very well, what does she want? If she wants the comorbidities resolved, so the gastric bypass is the best procedure performed in these patients. So thank you very much to the World Gastroenterology Association and IFSO to give me the opportunity to comment this case. We'll discuss this case with the other professionals. Thank you very much. God bless.
Thank you very much. And I'd like to ask Professor Barham Aboudeya to talk to us about his point of view.
Dear colleagues, my name is Barham Aboudeya, and it's my pleasure to present the endoscopy perspective on the case presented by Dr. Al-Numeri. These are my disclosures. It's very important to highlight the salient features of this case. We have a patient, a young patient with predominantly presentation of pathological reflux in the setting of a 3 centimeter hiatal hernia and esophagitis. She has a dysphagia, she's a smoker, and she's worried about the risk of any intervention. Her obesity is mild and she has advanced diabetes. I don't think the current state of the literature offers clear guidance about the most optimal approach for such a patient because of the complex presentation. In that setting, it's important to weigh the risks and benefits of each intervention and use the principle that the best interest of the patient is the only interest to be considered. With that, it's very important to highlight that her predominant presentation is reflux, and reflux is an interplay between esophageal physiology, gastric accommodation and emptying, and the anti-reflux barrier made by the diaphragmatic hiatus and the lower esophageal sphincter. It's not a hypersecretory disorder, thus just addressing parietal cell is not sufficient to address this disease. So the gastric bypass is definitely a reasonable option in this case, but it's very important to weigh the risks and benefits if we're going to embark on a gastric bypass versus a minimally invasive approach to her presentation. So the first question in that quest is to answer, is Rowa gastric bypass truly an anti-reflux procedure and the holy grail for GERD? And there's some evidence to suggest that it's a good procedure to decrease acidic reflux, but it's not necessarily improve volume reflux of weakly acidic or alkaline refluxate. This is a cross-sectional study of about 870 patients. About 256 underwent a Rowa gastric bypass and had endoscopy a few years after the procedure. And you could see that the acid reflux or presence of esophagitis was present in about a third of the cohort, and that's heavily confounded by the presence of a hiatal hernia. So this is also a corroborating evidence from a nationwide cohort study that looked at adults with preoperative reflux who underwent gastric bypass. And they looked at remaining or recurrent reflux more than 6 months after surgery. This is from Sweden. And they showed that about 50% of the cohort continued to have reflux or had recurrent symptoms requiring medication that remained stable up to 10 years after the procedure. So the issue is when you look at objective physiological measures of manometry and pH, that the Rowa gastric bypass does improve acid exposure time, but it does not significantly alter the total reflux episode, especially of alkaline or weakly acidic refluxate, as shown in this meta-analysis. And actually, the accommodation of the pouch might be problematic, especially in the setting of a hiatal hernia. This is a patient subjected to endoflip functional planimetry, and you could see that the gastric pouch is not very compliant, and there's a hiatal hernia present that with a non-compliant pouch, the force of the contractility is in a retrograde fashion to the esophagus, conducive to significant reflux in that setting. So if the risks benefit of gastric bypass are not sufficient in this case, what alternative I could give you from an endoscopic perspective? And I would argue that a combination of a proper anti-reflux procedure, which is a hiatal hernia repair, plus fundoplication and a minimally invasive endoscopic sleeve gastroplasty would be a better option. This is a very similar case to the one presented at the Mayo Clinic with a small hiatal hernia, about 3 to 5 centimeters, that we corroborated with our surgical colleagues in order to repair the hiatal defect laparoscopically and offered either a transoral fundoplication or a partial toupee fundoplication combined with an endoscopic sleeve gastroplasty, which is anatomy preserving. The advantages of the endoscopic sleeve gastroplasty, as shown in this functional MRI, is it does not affect the motility, the innervation of the stomach, thus the motility is intact. There's no dissection of the ligament, suspending the stomach with remaining accommodating small fundus, which also is not conducive to be a high pressure zone for reflux. You could see 9 months after the procedure, the patient has normalization of her Demetri score and a significant weight loss with a change in BMI from 46 to 29. But you might tell me, wait a minute, Dr. Abudeya, you forgot about the elephant in the room, and the elephant in the room here is poorly controlled diabetes mellitus, and for that, I would refer you to an important study published in the New England Journal of Medicine, and subject to you that the weight loss observed with the combination of hiatal hernia repair and endoscopic sleeve gastroplasty with a fundoplication is sufficient to have improvement or remission of type 2 diabetes. Again, with this New England Journal of Study, they subjected 15 patients to gastric bypass, matched them to cohort that underwent low caloric diet and achieved the same exact 18% total body weight loss. They did a battery of sophisticated testing, including a hyperinsulinemic euglycemic pancreatic clamp that showed identical improvement in both groups. And when they looked at 24 hours glucose profile, 24 hours insulin profile, beta cell function, and body composition, all were equivalent as long as the weight loss was significant, and in that case, more than 18% total body weight loss. And with that, I conclude and thank you for your kind attention.
Thank you so much. And next we have Dr. Shelby Sullivan, and we'll hear her presentation. Thank you.
Hi, my name is Dr. Shelby Sullivan, and I'm going to be discussing this case today. And I'd first like to thank the organizers for inviting me to discuss this case that we'll be talking about, including a patient with class 1 obesity, GERD, and type 2 diabetes. These are my disclosures. I've been involved in a number of research studies on endoscopic bariatric therapies, and I consult for a number of endoscopic bariatric therapy companies. So there are several issues with the patient that was presented today in this section. And that includes the BMI of the patient. She has a BMI of 34, which in the United States would preclude her from getting insurance coverage from many insurance carriers for a bariatric surgical procedure. The next issue with this patient is that she has GERD that's uncontrolled on a PPI, and she also has a significant hiatal hernia of 3 centimeters. This also affects what kind of therapies we would be willing to do and what kind of surgeries we'd be willing to do for this patient. She's also a smoker, so that puts her at risk for surgeries, but also puts her at risk for cardiovascular disease as well. Her diabetes is not currently at goal, and she's also not on medications that would be recommended as second-line treatments in the American Diabetes Association treatment algorithms for the treatment of diabetes. And this is an important point. We're going to go over that right here. So this is a very busy slide, but essentially this goes over the algorithm that the American Diabetes Association recommends for the treatment of patients with diabetes. The first-line therapy for any patient with diabetes in America, the recommendation is to start off with metformin. The next therapies, though, really depend on patient characteristics. And we're going to talk about this in this next box that I've highlighted here in a little bit more detail. So the next step is really to decide to determine whether or not the patient has risks for cardiovascular disease or currently has cardiovascular disease, chronic kidney disease, or heart failure. And if that is the case, in particular with cardiovascular disease, the next therapies that you would want to consider as the second-line medications would include either a GLP-1 receptor agonist or an SGLT2 inhibitor. So they both have indications for lowering cardiovascular risk. And in this patient who has diabetes, a class 1 obesity, has a history of smoking, has hyperlipidemia and hypertension, that patient is at high risk for cardiovascular disease. It's also most likely, based on all of these characteristics, that she likely has non-alcoholic fatty liver disease as well, which again is putting her at a higher risk category for cardiovascular disease. These medications have data with lowering risk of cardiovascular disease. And in particular, GLP-1 receptor agonists also have benefit not only for diabetes, but also for patients who have non-alcoholic fatty liver disease as well. In addition to that, both of these medications have weight loss benefits, the highest weight loss benefit being with semaglutide. So then when we really think about the options for this patient and how I would think about this patient in my clinical practice, first and foremost, regardless of what therapy you were doing, you would want to have this patient quit smoking. And one of the things you can add to help with the patient smoking cessation is bupropion, which does have an indication specifically for smoking cessation and can also help with weight loss as well. So the next thing I would do is have shared medical decision-making with the patient. And the first thing I would discuss is whether or not the patient would accept a surgery or a procedure. If the answer to that is no, then we go with really intensifying both medications and lifestyle therapy. And I would talk to the patient and try to get the patient on a GLP-1 receptor agonist, specifically semaglutide. This would have to be done in conjunction with the patient's either endocrinologist or their primary care physician, because their insulin does need to be adjusted and decreased while they're starting this GLP-1 receptor agonist, because it will lower their need for insulin. I would also intensify their lifestyle therapy. This is both to help for weight loss and also to change behaviors that may be worsening reflux. And then we would make sure the patient is on high-dose PPI therapy and Carafate. If the patient is willing to undergo a surgery or a procedure, I would first talk to the patient about gastric bypass. Now, again, in the United States, this is likely not going to be covered by insurance because her BMI is less than 35, but we could still discuss the option and also consider whether or not the patient may be able to pay out of pocket. And this is different for other countries. In addition to that, I would still discuss whether or not the patient may benefit from a GLP-1 receptor agonist. The other option is that the patient could undergo an anti-reflux surgery that would help with reflux and to treat her hiatal hernia, and could also undergo an endoscopic bariatric therapy, specifically an endoscopic sleeve gastroplasty or the Aspire Assist system. In this patient, I would not proceed with an intragastric balloon because that could worsen her reflux. And if she did undergo an anti-reflux surgery in her foregut, that would be a complete contraindication to getting an intragastric balloon. In conjunction with those therapies, I would again also think about adding a GLP-1 receptor agonist, specifically semaglutide, to help treat her diabetes, lower her cardiovascular risk, and again, if she has non-alcoholic fatty liver disease, which she likely does, would also help with that as well. Thank you.
Thank you, Shelby. Last but not least, let's hear from Mary O'Kane, the wise words of a dietitian. Mary.
Thank you, Dr. Namiri, for this case presentation. And it's a real pleasure to be taking part in this webinar today. These are my disclosures. So as a dietitian, I'm interested in the whole person and I want to know more about the social history. The weight history of this patient is already known and she's had many past attempts at trying to lose weight. And I'm also very interested in her current dietary intake and her eating patterns and how this fit into her typical day. I'm concerned that she has dysphagia and I would be looking at the quality of her diet and also requesting nutritional bloods to make sure that she hasn't got any nutritional deficiencies. I would like to know whether or not she has a history of eating disorders. And then when we're looking at the options, we're looking at intensive lifestyle interventions with or without anti-obesity medications and also bariatric and metabolic surgery. So there's many recommendations about what people should do with obesity and type 2 diabetes. And these Canadian guidelines highlight the fact that lifestyle interventions where people can lose 7 to 15% of the total initial weight loss will help to improve diabetes control and help resolve some of those other comorbidities. There's lots of evidence pointing towards this, and I'm just going to talk about two studies, which is the Look Ahead and the Direct study. And both of these had patients with overweight and obesity and type 2 diabetes. In the Look Ahead study, those who received the intervention, because this is a randomized control trial, had structured meal plans and meal replacements over the year, and then years 2 to 8 focused on weight maintenance. And what they found was that those who achieved 7% weight loss had improved glycemic control. The Direct study is also an RCT, and in this, for the first 12 to 20 weeks, those receiving the intervention had low-calorie liquid meal replacements, and these were just over 800 calories a day. This was then supported with food reintroduction and a focus on weight maintenance. And what they found that a year that if people had managed to, that 46% of participants had managed to achieve diabetes remission at a year, and 36% at 2 years. And those who lost 10 kilograms had good outcomes, and those who lost 15 kilograms had even better outcomes. However, one must remember in this study is that people had type 2 diabetes for less than 6 years and were not yet on insulin. So there's evidence pointing to the fact that if people have interventions early when they've had the recent onset diabetes and are not yet on insulin, there's a greater chance of people having diabetes remission. But obviously Our Lady has had diabetes for some time and is already on insulin. Also, a number of guidelines recognise that early intervention, again with recent onset diabetes and also with class 1 obesity, is more likely to achieve better outcomes. And the Canadian guidelines, like others, recommend that bariatric surgery should be considered if people are not optimally managed with medical treatments. And in this study, the Stampede study looked at intensive medical treatment, which would have included anti-obesity medications versus bariatric surgery in people with type 2 diabetes and obesity, and there's a 5-year follow-up. So for me, what's interesting in this study is it's a mean duration of diabetes for 8 years. and that 36% of those going forward for surgery have class 1 obesity. And what they find is that 5 years that those who go forward for surgery have a greater weight loss, they have better diabetes control, and there's a reduction in medications, including insulin. So this is definitely an option for this patient. However, it's not just about the weight loss, it's also about weight maintenance and avoiding weight regain. And I just mentioned the SOS study, and this is not a randomized controlled trial. It's where people went either down the surgical arm for weight loss or medical treatment, which should include obviously lifestyle interventions. And what you can see in the left-hand graph is the 20-year outcomes, and it shows that those who go forward for bariatric surgery are likely to have a lower weight at 20 years than those who went down the medical intervention group. But we must remember that this is not a randomized control trial. People were lost to follow-up, and even with the surgical group, there can be some intense weight regain. When we look at the ones who went in the medical group in the right-hand graph, you can see that after 2 years, many people will regain weight, and for some it will be significant. However, I want to just highlight that at 10 years, that there were a number of people who were still managing to achieve those clinically significant weight losses. So what's the best for this patient? I think it's really important that we discuss options, and this could include the intensive lifestyle interventions with or without the anti-obesity medications. Another option obviously is the bariatric and metabolic surgery. And as a dietitian, what I want to do is present objective information to this patient, empowering her to make an informed decision as to what is best for her at that time. So thank you for your time, and I look forward to the panel discussion.
Thank you very much, Mary. We're going to open this for discussion with the panelists as well as the speakers. I'll also like to remind our attendees that they can actually send in their questions, and we'll try and answer those questions as well. My first question is to our panelist, Gerhard Prager. We heard that this patient does not qualify for metabolic or bariatric surgery in the USA. Would this patient qualify for surgery in Austria and in Europe?
In Europe, we have a very different situations. We have very strong public healthcare systems. At the moment in Austria, she will not have coverage from the public healthcare insurance. Saying that in Switzerland, she would have coverage. So you have very different situations. I would try to fight for this patient for coverage. So you can get an individual solution. So I'm very confident that even in Austria, although it's not covered on average, you would get coverage for this patient. I think this would be a very nice case of real metabolic surgery, as the weight loss is not in the focus, but with the uncontrolled diabetes and reflux, I would totally agree that Roux-en-Y gastric bypass is the way to go, for me at least, at this patient.
Are you concerned about her smoking history?
Definitely. I think this is something we have to consider. She must quit smoking before having surgery, or at least that's what I would stress on. And of course, from a surgical point of view, you can play around with the size and length of your pouch. The more stomach you have in the food stream, the higher the risk for anastomotic ulcer will be.
Eamon, I'd like to follow up by asking you, do you think there's any undiagnosed motility disorders in these patients? Should they undergo manometry routinely, even though it's sort of not standard of care at the moment, unless they have any symptoms? Because sometimes we've seen patients with bariatric surgery sort of 5-10 years out who present with things like achalasia.
Achalasia would be my only worry, and that can be actually screened for maybe more simply by doing a time barium study. Not easy to get in a lot of places. But there's one other point I wanted to bring up, and that we seem to have forgotten. This patient was Helicobacter pylori positive, as far as I remember, correct?
Yeah.
Yes.
So we're talking about a patient who's got a precancerous condition of her stomach, and we're talking about excluding the stomach. So what comments do the surgeons have to make about this?
So I would, of course, eradicate these patients. We do endoscopy in all our patients preoperatively. And if we have H. pylori positive patients, we do eradicate them. That's our strategy.
I do agree.
But it wasn't mentioned.
That is true, but even for any of the endoscopic procedures as well, I always check H. pylori before any endoscopic procedure, any endoscopic bariatric therapy.
I just want to mention that after sleeve gastrectomy, we've just published a few weeks ago our 15 years data, and we also published our 10 years data. And after 10 years, this is a real refluxogenic operation. And I have no idea why an endoscopic sleeve gastrectomy would be different in that part of the game.
And Barham can speak to this as well, but there has actually been a comparison. Vivek Kambari published a series comparing sleeve gastrectomy to endoscopic sleeve gastroplasty, and there's less reflux that occurs after endoscopic sleeve gastroplasty compared to sleeve gastrectomy. And part of the reason why, and Barham brought this up in his talk, is that you are leaving the top part, the fundus of the stomach, open. So you do have this essentially non-pressurized system at the very top of the stomach. And so that may contribute to the lower rates of reflux that we see after these patients. And from an anecdotal standpoint, clinically, most of my patients after endoscopic sleeve gastroplasty do not have reflux or do not develop reflux symptoms.
I agree with Dr. Sullivan, and I will add, we looked at this in the MERIT, which is the US multi-center randomized trial, which will come out soon, hopefully in IFSO, that reflux is not a major contributor to the endoscopic sleeve. So I think we've settled that issue, and now there's actually pH per data that will support that notion as well.
My concern is also the fading of efficacy with time, which we see in the sleeve gastrectomy, and I would also expect for the endoscopic sleeve gastrectomy. But this is just my personal concerns.
And that's a real concern, and that's why if I have to have a crystal ball and say what's the future is going to be you have two strategies. One is a strategy to lose the weight and put the disease into remission. And I say remission, not cure. There is no cure for this disease. And the second would be for weight maintenance with a multitude of tools that we have at our disposal now, including a lot of good medications. So I think the future is going to be as such with these combinations.
And I think the other thing that we need to keep in mind, and Barham just made a point on this, is that there is no perfect procedure. And especially for those of us, about a quarter of my population is actually patients who've regained weight after gastric bypass. So there's weight regain that can occur with any procedure. And I think that we need to be vigilant about it and develop management strategies for that.
But especially
if there's one comment I would make to support what Gerhard said, is that 5 years after sleeve gastrectomy, when surgeons were told that it might cause reflux, they said it doesn't. We did not figure out that it causes reflux and Barrett's except 10 years out, 12 years out, 13 years out.
If I may, I'm going to be a little controversial here, Abdurrahman. You know, this lady that you presented obviously has florid metabolic syndrome. But what worries me most about this patient, the characteristic of her smoking. She's a heavy smoker. And from a surgeon's point of view, who's treated these patients for over 20 years, the thing that scares me most, the thing that gets me up at night most often is marginal ulcers and their bleeding and their pain and their perforation. And I've learned over the years that heavy smokers are simply not going to quit. They're not going to quit smoking. Or if they do, they come back and start smoking again after surgery. And frankly, to me, that is a huge factor in my decision-making process. Now, we could give her a sleeve, we could fix the hiatus hernia at the right time, at the same time, and then who knows, the weight loss might reverse her GERD, her esophagitis, and then survey her for the occurrence of Barrett's. And frankly, I know I shouldn't be saying this, but the sleeve gastrectomy doesn't burn bridges. Worst case scenario, if her reflux returns or Barrett's develops, then you can convert her. The other important point is the lady came asking for a sleeve. And the other thing that I've learned over the years is you have to listen to the patient, because you could convince her to get the gastric bypass, but she's going to be always hostile about it. She's going to say, I did not want this operation. Just some thoughts to bear.
So Summer, you're going to give us sleeve gastrectomy and repair a hiatus hernia. Would you give us sleeve gastrectomy and the links?
Yeah, possibly a links, or maybe reserve the links to later, or reserve the strata to later. If I'd give the chance to see if the weight loss alone might improve her reflux. If it doesn't, if you have a well-constructed sleeve and a patient who's losing weight, I think the chances are her GERD will reverse. Remember, as Barham very eloquently demonstrated, the Roux-en-Y gastric bypass is not the holy grail, as you said. At least 15 to 20% of patients with gastric bypass have reflux disease. So yeah, I would probably just fix the hernia and just reserve endoscopic procedures or the links should the symptoms recur.
One point I would add to this discussion is there's dysphagia as well. And I have to say there's an evolving, still premature, but evolving body of literature to suggest a new entity that's called POSIT, or post-obesity surgery esophageal dysfunction. It's a pattern that we still do not understand. It's characterized by dysphagia, characterized by absence of secondary peristalsis and ineffective esophageal motility. It's hypothetically due to increased afterload on the esophagus from years of exposure to high pressure zones. Still, we don't know if it's reversible or not, but this is something to keep in mind with these procedures for sure.
Can I ask about the links? Is the hiatal hernia not too big for a links?
In this case, it is.
And also, links could make her dysphagia worse, even though her manometry does not show motility disorder.
That's why I would just repair the hernia and then see what happens.
If I would make just one comment, I think Shelby Sullivan really is very astute at picking up that the patient is not on the best medical therapy. I mean, this patient has several things that need time with a dietitian, an obesity medicine specialist, time to treat H. pylori, get her on the right medication, and maybe in 6 months, she'll be a different patient.
I can tell you that, one of the first things that I do when I see patients is first, what's going on with their current medications that they're on. I am not a diabetologist. I don't suggest that I am one, but I do try to follow the guidelines. And it is amazing what can happen when you get patients off of medications that are contributing to their weight gain and onto medications that can cause weight loss. And in this patient, if she's a super responder to semaglutide, then you might get 15% total body weight loss, even at the diabetes dose of semaglutide. That's not going to be the average, but some patients are going to get there with that. And then would you need to even, go to a surgery, or, you would still consider maybe an anti-reflux surgery at that point?
But I would be hesitant to do any refluxogenic operation in this patient because her Demeester score is exceedingly high. It's more in the supine position, which tells you she has proximal migration of the Z-line already. She has a hiatal hernia. And in a patient like this, I would be very hesitant to offer her anything that causes reflux. One thing we do in the US for someone like this is to approach the insurance company not as a weight loss operation, but to tell them this is a patient with documented reflux who needs surgical therapy, and show them the literature that a fundoplication has worse outcomes and a high recurrence rate long-term, and that the procedure we're doing is merely to treat reflux. And we've been very successful in convincing insurance companies to offer her, once she's ready, a Roux-en-Y gastric bypass at this BMI or even lower, if we prove that the #1 indication is not weight, it actually reflux.
And I think that might be region to region dependent too, because we have not had as much luck in Colorado with that.
Mary, there's a question for you. I mean, you eloquently showed the SOS study with weight regain, and we often see that with various different types of surgery, also with different types of endoscopy. So how do you help your patients achieve a targeted weight loss and maintain that weight loss? How often do you see them? What kind of diet do you recommend going long-term after they've finished their bariatric diet?
I think one of the first things I need to mention is that the long-term follow-up available to many patients isn't as long as it should be, because it should be lifelong. But certainly in that first year, there'd be intense dietetic support, helping the patient reintroduce foods, reintroduce textures, actually learn to eat the smaller portions, and actually gradually moving that person back towards 3 meals a day. And there's some interesting work that's been done by Dr. Mitchell and his colleagues, looking at the fact that if people can return to 3 meals a day, stop eating before they feel full, that they're more active, that they don't graze, they're going to have better outcomes. And this is saying from many studies as well. So it's about how that first year is more focused on the weight loss. The second year is on the weight maintenance. And then really what we need to be able to do is actually help people have that longer term follow-up. But in the UK, certainly in our health service, we're only able to give 2 years follow-up, and then we have to discharge back to primary care. And what I'd like to see that there is a model, even if people just have access to annual reviews and just that annual monitoring, so we can actually keep a check, because inevitably there can be weight gain as we age, but for some it can be more intense than others. And then I think it's already mentioned that the new medication that's coming online, which is not as available in the UK, that may also help that weight maintenance phase.
Thank you. And I know we focused a lot on GERD, but I want to sort of ask Professor Kasama, would you consider if the patient, let's say, didn't really have GERD and just the diabetes part, what would be the optimal surgery that you would offer her? We discussed this sort of in the first session, but I think with the case presentation, I want to hear the panel's opinion as well.
Yeah, I would like to offer her gastric bypass with hiatal hernia repair. So actually that she had H. pylori positive, but if eradication works, it doesn't matter so much. So that the gastric bypass is the better option for her, even she had the hiatus hernia or not. So from the viewpoint of remission of type 2 diabetes, I think that the gastric bypass is good for her. And also the gastric bypass is good for her, the GERD, if she had hiatus hernia repair simultaneously. Also, she may have one of the biggest objective on gastric bypass is a smoker. If she can quit smoking, the gastric bypass is the best. But if she cannot, the sleeve gastrectomy is the second best option.
Thank you. Barham, do you routinely do endoflip on these patients? I saw, obviously, you did it in this patient who had GERD and dysphagia-like symptoms, but sort of going back to my question to Eamon, what about the undiagnosed manometric issues?
Yeah, Reem, so thank you, Dr. Sharha. It's an interesting phenomena that we recently report in the Red Journal, the American Journal of Gastroenterology, this entity of POSIT, or post-esophageal surgery endoscopic dysfunction, or esophageal dysfunction. And since then, we've been interested in seeing why this happens. Is it a chronicity issue? Is it a time-dependent phenomena? On a study, we've been doing endoflip on obese matched cohort versus those undergoing bariatric surgery at different time points to try to elucidate some of the functional physiological changes that happen to the esophagus with time after the different iteration, whether it's obesity alone, endoscopic procedure, surgical procedures such as sleeve and rowa gastric bypass. So I would say we've done it now. I think we have a cohort of close to 120 patients And we're going to continue to do this to hopefully get more clarity on what's happening to the esophageal physiology with time after these operations, which is an important metric that we need to follow for sure.
Great, thank you. And I guess this also follows the second question from the audience. Also, you could probably answer, or any of the surgeons who do the combined TIF procedure. So what about the combined C-TIF followed by a surgical sleeve, not an endoscopic sleeve? I guess any of the surgeons, if you have experience, and I know Barham has some experience as well.
I haven't.
You do?
No.
Okay. Barham, then I guess the question goes to you again.
So yeah, I mean, that's the key is, again, if we go to the prism, the interest of the patient is the only interest, and we work as a team to take care of the patient, then you'll see this collaboration between surgery and endoscopy to achieve something that individually we cannot achieve together. So yes, we do collaborate with our thoracic surgeons a lot to offer these hiatal hernia repairs plus a toupee with an endoscopic weight loss options, especially for those with GERD and BMI above 35, because right now there's the only alternative is gastric bypass, as our colleagues stated. So this collaborative procedure happens a lot actually, and we will continue to push the limit with this collaboration. And I think the future is as such is we are one team taking care of a patient, and we should do it together with the best interest of the patient for sure.
Okay, great. Mary, this question's for you, but then I'll throw it out to the rest because I know I often get asked this as well. Do you recommend intermittent fasting as a way of weight maintenance or weight loss? And if so, for how long? And which type of intermittent fasting do you do? Is it this sort of the 2-5 or just the reducing the number of hours?
I think I'm always guided by the patient because different things work for different people, and there is no evidence as yet that one diet is superior to the other. So for some people, if intermittent fasting works for them, happy to work along with them, make sure that what they're doing is safe, that it's nutritious, that they can afford it and they can adhere to it. But equally, if they want to try some other way to lose weight, I'm quite happy to support that as well. But the recent reviews I've seen don't show that one way of trying to lose weight by diet is actually superior to another sort of diet.
Great, thank you. And Professor Prager, yeah.
If you present this case to 100 surgeons, we're going to have a lot of opinions, but most of them are going to say that this is going to be a gastric bypass procedure. And I have a question for the surgeons. The length of the limbs in this case, if a gastric bypass is done. Thank you.
I would, should I start? If I was if I was going to do a gastric bypass on the patient, the the roux limb would be at least 100 centimeters because she already has a tendency to have acid reflux. And so we want to prevent or minimize the chance that she might have a alkaline or bile reflux. With regards to the other limbs, you know, her BMI is 34, I believe. So dramatic weight loss is really not necessarily an objective here. So I would make sure that the BP limb was no more than certainly less than 1 meter, maybe 60, 70 centimeters long.
Gerhard?
Yes, for me, we go for the elementary limb, a minimum of 70 centimeters, because this is the minimum length to prevent bile reflux. So I'm pretty in accordance with Samer. And for the BP limb, as short as possible, around 40, 50 centimeters. So I can just echo what you said.
Dr. Nimeri?
Yeah, I agree. 100 centimeter roux limb, 50 centimeter BP limb for the same reasons outlined by Samer and Gerhard.
Dr. Kazama?
Yeah, 50 centimeter of BP limb and 1 meter of the elementary limb, just like the other.
So we surgeons, we do agree that this case fits for a gastric bypass. Is that correct?
Let's hear from Lillian. I have not heard the limb length from Lillian.
No, I do agree. 50 and 100 is what I would do.
But the second question, we do surgeons do agree that this is case for gastric bypass? I heard that Summer says that
I don't agree. I'm more concerned. I predict that I will have more problems with marginal ulcers than with reflux in this patient if I give her. You know, the chances of having reflux issues with the sleeve, I think, are going to be less than the chances of having smoking-related complications, even in the face of maximum PPI prophylaxis.
So if I can make a comment, I think because she has objective evidence of reflux with very high Demeester score, I'd be hesitant to give her a sleeve. As I said, I think she deserves to spend some time with a dietitian and an obesity medicine specialist to better control her diabetes and maybe control her weight a little bit. But I do think marginal ulcer will prove to become a technical complication, just like internal hernia. The size of the pouch we make affects the marginal ulcer significantly. We now have literature to show that H. pylori doesn't. Smoking does, so the time she'll spend with the obesity medicine specialist is also a time for me to understand her smoking behavior. But I would certainly spend time with the team and then a Roux-en-Y gastric bypass.
I fully agree with Abdelrahman. I would not do a sleeve gastrectomy in a patient who suffers from GERD preoperatively.
So I'm going to end at this controversial note. I think the key answer here is to listen to our patients, understand their comorbidities and their habits, because that could interfere with any type of surgery that we choose. Thank you again to our panelists and speakers and my co-moderator for a great second session, and we'll be back after this break. Welcome back, everyone, and welcome to our final session on the impact of COVID, the other pandemic, on this obesity, the ongoing pandemic. So we thought this would be a very interesting and hopefully lively discussion. I'm going to first start by introducing our panelists and our speakers. We have Dr. Arya Sharma from Canada, who's a professor emeritus of medicine and past chair in obesity research and management at the University of Alberta in Canada. He's also the past clinical co-chair of the Alberta Health Service Obesity Program. He's the founder and scientific director of the Obesity Canada, which is formerly the Canada Obesity Network. And he is a fellow of the Canadian Academy of Health Sciences and past president of the Canadian Association of Bariatric Physicians and Surgeons. Secondly, I'd like to welcome Professor Lou Aroney, who works at Weill Cornell, where I work. So welcome. He's a professor of metabolic research and then he's the medical director of the Comprehensive Weight Loss Control Center. Dr. Aroney is a leading authority on obesity and its treatment at Weill Cornell, and also state-of-the-art multidisciplinary obesity research treatment center in the Division of Endocrinology, Diabetes, and Metabolism. He's the past chairman of the American Board of Obesity Medicine and the former president of the Obesity Society. He's also the founder and CEO of BMIQ, a web-based weight management system for the healthcare providers. Welcome, Dr. Aroney. Secondly, I'd like to welcome Dr. John Morton. John Morton is the system lead for the surgical quality and bariatric services in the Yale New Haven Health System of 6 hospitals, and the vice chair for quality, division chief for bariatric and minimally invasive surgery, and a professor in the Department of Surgery at the Yale School of Medicine. He served as the chief of bariatric and minimally invasive surgery, clinical chief for the bariatric and metabolic interdisciplinary clinic, and the director of bariatric and minimally invasive surgery fellowship at Stanford University School of Medicine from 2003 to 2019. So welcome. And now our speakers. We have Professor Scott Shakura, who's the professor of surgery at Harvard Medical School. He's a director of the Center for Metabolic and Bariatric Surgery at the Brigham and Women's Hospital in Boston. He's the president-elect of the International Federation for the Surgery of Obesity and Metabolic Disorders, and he's currently the editor-in-chief of Obesity Surgery. Welcome. We also have Dr. Christine Stier, who is a surgeon and endoscopist from the University of Hospital of Wurzburg in Germany. She's the head of surgical endoscopy department, the head of the Interdisciplinary Obesity Center, and she's a member of the IFSO endoscopy committee. We also have Dr. Ivo Boscoschi, who is from Italy. He is a trained diagnostic and operative gastrointestinal endoscopist and biliopancreatic endoscopist with a fellowship at the Digestive Endoscopy Unit of the Catholic University of Rome, which is directed by Costamagna. He is the instructor and member of the faculty of the European Endoscopy Training Center, and his particular interests is simulators, ERCP, and endoscopic devices for weight loss. He's also a co-investigator of several trials at the Catholic University. And last but not least, we have Julie Parrott, who is the Bariatric Nutrition Care Coordinator at Temple University Hospital, Philadelphia. She's an adjunct assistant professor at Rutgers University at the Department of Nutritional Sciences and a visiting research fellow faculty of Health Sciences and Wellbeing at the University of Sunderland. So welcome all. And thank you very much for being in our session. I'd first like to start by launching our poll. And the bariatric surgery, the poll states, the bariatric surgery performed on low-risk patients demonstrated that there was a high perioperative complication rate. Surgeons had a high incidence of contracting COVID-19. BMI was shown to be an independent risk factor for complication. and surgery during the pandemic had a very high complication rate. And while attendees are answering this question, I'd like to invite Professor Shakora to comment on this poll and what you think the answers should be.
Okay, well, thank you very much. It's an absolute honor to be part of this and also to be connected with so many of the greats in our field. Just the names you mentioned alone is an all-star lineup. If you go back to the lockdown, which happened pretty much at the same time around the world, there was generalized panic through the medical community because we didn't know a lot about the virus and we didn't know what we didn't know. So what they did was locked everything down, partly to reduce the risk of transmission of the virus, but also partly because they had to shift those same resources, such as ventilators and beds, out of the ICUs and up to the, out of the ORs and up to the ICUs, because there were so many patients being admitted that had to be ventilated due to their COVID. So to accomplish that wisely and pretty much consistently around the world, the what was considered to be elective cases were all closed and shut down for the length of the lockdown. And what we know now was that that probably was unnecessary, number one. And number two, that patients who have the complications of obesity have more risk factors with that than they did with the virus. Therefore, preventing them from having timely surgery probably hurt a number of patients who might have developed complications or other problems while they were waiting for the lockdown to end and the ORs to be opened up again. But also because if you look in the literature, we learned a number of things. Number one, the transmission was not spread out, of the virus was not spread out through the health community. There were no reported cases of surgeons, anesthesiologists of any significant number getting COVID. And I think because they followed universal precautions. In addition, patients who had surgery prior to the risk of COVID were not at any higher risk of developing COVID. In fact, it appeared it might have been somewhat protective. And the numbers of patients who had bariatric surgery who then went and then were followed, very, very few of them came down with COVID, and those that did, it was a much more mild experience than for others. So there may have been some protection to it. We also learned that BMI was an independent risk factor for complications, that patients who were higher BMIs had a greater risk of being transferred to an ICU and intubated. So in retrospect, we probably could have continued to perform surgery on patients of weight during the lockdown. We didn't have to shut them out completely. And maybe next, fortunately, there hopefully won't be a next time, but if there was a next time, maybe we would know better.
Hopefully not. So the answers are here on our right. I know you touched upon the answer, but would you care to comment before we start your presentation?
Just that the people with high BMIs were more likely to get COVID and more likely to get a fatal COVID infection, and that bariatric surgery might have been protective for these same people who had that surgery prior to the lockdown. And lastly, that we maybe should reconsider locking down completely bariatric surgery because it is not elective surgery. We're treating diseases with it, as we've heard all morning.
Great, thank you. And without further ado, we'd like to ask you to present your talk on surgery and COVID. Thank you.
Hello, I'm Dr. Scott Shakora, and I'm going to speak about the impact of COVID-19 pandemic on patients with obesity, as well as the bariatric surgeons. These are my disclosures. None of them have any bearing on this presentation. Well, we all know the COVID-19 pandemic and lockdown resulted in dramatic changes to patient care, especially in surgery. All elective surgeries were postponed to limit patient exposure, but also to free up hospital resources to care for the COVID patients. Hospital and government policies were created to limit the spread of the pandemic, and care algorithms were created uniquely for COVID. This presentation will review how these policies affected bariatric metabolic surgery. Well, there are a number of issues that have to be addressed. First and foremost, is bariatric metabolic surgery truly elective? It was considered so by most of the world, and the cases were postponed when they needed to shut down ORs. But should those patients have been offered surgery because of their comorbid conditions? And as you know, the clock is ticking on these patients. If they don't have surgery, they may die from heart disease and diabetes, etc. We do know that patients with severe obesity are at greater risk of contracting COVID, and patients awaiting bariatric surgery are at risk of developing one of the complications of their obesity-related diseases that I just mentioned. Will patients be at a higher risk for complications if they have surgery during the pandemic? And what about the bariatric surgeon? Are they at increased risk being in the operating room, operating on COVID patients? Well, we have to first of all prioritize who gets that surgery, since we're limiting the surgery to preserve resources. And we could either look at the low-risk population, where we would expect the complication rates to be lower, but maybe the benefits to be less because they're healthier, as opposed to the higher risk patients, where the surgery may be more difficult and there may be more issues to contend with for recovery, but these patients have more to gain from the surgery. The world basically selected the low-risk patient to reopen the operating rooms with. However, I, once again, would put a plug in that we should consider the high-risk patient and not completely shut them out, because they are so needy of having these bariatric procedures performed. What about the eligibility for surgery? This here by Angrisani is basically the algorithm used by most places to qualify patients for surgery. And what they were looking at are basically the healthier patients, no past history of COVID, younger age, lower BMI, less likely to have comorbid conditions. But once again, I want to make a plug that we should at least consider some of the higher risk patients for surgery because they need it so badly. So patients who had COVID but fully recover, patients who are older, up to age 75, higher BMIs with medical conditions, assuming those conditions are well controlled. And this would be my eligibility list for bariatric surgery. Now, we do know that obesity is a risk factor for contracting COVID and for having more severe cases of COVID. And to show you a little bit of data, this study looked at 700 patients that came to the hospital, were diagnosed with COVID. And what it demonstrates, it broke it down into a low weight BMI, average BMI, and a high BMI. And what you could see here is that ICU admissions and intubations were much more likely seen in patients that were obese than in patients that weren't obese. And the death rate was highest actually in the lower weight patients, which may reflect the fact that they may have had other health issues, etc. Bariatric surgery has also been demonstrated to be safe. This study looked at over 2,000 patients from 35 countries. They all had bariatric surgery during the pandemic, and we had 30-day morbidity mortality data on these patients. What you could see here are remarkable numbers, only one death at post-op day 18 in a COVID negative patient. Most of the complications were mild. 10 patients contracted symptomatic COVID for a very low incidence of 0.5%, but there were no deaths, there were no ICU admissions, and 7 of the 10 patients required no treatment. Clearly a difference. And is bariatric surgery protective? In this study, a telephone survey of 2,145 patients who had bariatric surgery in the past, that the number of patients who developed symptoms suggestive of COVID was 8.4%, which is about the average for people who are not overweight. But amongst that group, only 6% tested positive for COVID, so 0.6%. So most of them actually didn't even have COVID. and very few were admitted to the hospital and very few needed ICU care. So the bariatric surgery may have helped this group of patients ward off COVID to a greater degree than anything else that we had available to us. Now, I'm not suggesting we take a cavalier approach to things. COVID is still a dangerous and deadly infection, so things have to be done differently. And it starts with the operating room. Instead of positive pressure ventilation, it needs to be negative pressure ventilation. We need to minimize smoke by using closed circuit smoke evacuators and avoiding electrocautery in favor of energy devices that don't produce smoke, like the ligature or the harmonic scalpel. Non-essential personnel need to be out of the operating room, particularly the first 20 minutes or so during intubation and induction, and also during the waking up and extubation phase at the end. The patient has to understand, number one, that no one can accompany them to the hospital for their surgery and visit them while they're in the hospital. They need to do a 14-day self-quarantine after surgery. They need to understand they'll all be tested for COVID-19 one day prior to surgery, and many of them may end up getting a chest ultrasound, which is superior to a chest X-ray or CAT scan for looking for pulmonary disease from COVID. And the surgeon has to basically dress for battle. Universal precautions, droplet and airborne precautions. Double gloves, I think, is critical. Eye protection, shoe covers, and the use of the N95 masks. So what have we learned from the pandemic? We've learned that obesity is a risk factor for both contracting COVID-19 and for also having a poor outcome. Bariatric metabolic surgery was performed safely in patients during the lockdown, during the pandemic, and previous bariatric metabolic surgery proved to be protective, and few patients who have had surgery and had good results contracted COVID-19. So in conclusion, the COVID-19 pandemic and the lockdown created a new system for conducting surgery, and I have a feeling some of these changes are likely going to remain in place. Bariatric metabolic surgery was designated as elective and completely shut down, but should it have been? I would suggest not. Ultimately, it was offered, but only to low-risk candidates, and I would now say we have enough data to suggest that because high-risk patients have much to benefit and that we can produce safe results even during COVID pandemic, that we should be able to at least consider these patients for surgery and not universally reject them. Thank you very much.
Thank you so much, Scott. And now we're going to move on to Christine's presentation for the endoscopist's point of view.
Dear chair ladies and chairmen, it is my pleasure and a great honor to contribute to this eminent meeting and report the impact of COVID-19 pandemic on patients with obesity from the endoscopist's view. Here are my disclosures. COVID is like the plague. We had to learn about its contagiousness, special ventilation techniques, the cytokine storm, long COVID, neuro-COVID, spike proteins, mutants and variants, and PPE, the personal protective equipment, as well as that COVID has a life-threatening impact on patients with obesity. Both are global pandemics and a serious threat to global health. Just as COVID has hit the entire world with the speed of a deadly hurricane, the obesity pandemic is much more comparable to the effects and speed of climate change and the initial slow and now inexorably rapid melting of the poles. Obesity is more quiet than COVID, much more quiet actually, and it does not attract as much attention as COVID does. And Just as climate change, it has been simply ignored for a long time as a chronic disease of pandemic magnitude. Both pandemics, COVID and obesity, generate high mortality rates, and in people younger than 50 years of age, obesity appears to be the #1 major risk factor for ventilator dependency, more severe courses, and an increased COVID-19 mortality. The context for this seems to be the chronic inflammatory state that accompanies obesity. This leads per se to an abnormal cytokine production, such as interleukin-6, as we were able to show with this study, but also to an increase of various other acute phase reactants, with that apparently favoring and setting the trigger on the COVID-induced cytokine storm. But what in particular represents the endoscopist's view of the problem? At the beginning of the storm, the drama's first act, which was now more than 1 year ago, the world and us have been caught ice cold. Especially anesthesiologists and us endoscopists were and still are literally face to face, or rather face to aerosol, and thus extremely and dangerously close to the contagious virus. We had to understand and to learn this in the beginning of this lethal pandemic. We had to recognize that our work was actually permanently right on the front line of the virus. And the drama's climax appeared quickly. There was a global shortage of PPE, especially face masks. Under the threat of a warning, the wearing of masks on wards was banned in many German hospitals during March and April 2020. The unpreparedness and imprudence, and thus the lack of equipment, was declared a terrible waste of resources. Personal protective equipment was still a foreign word and initially sacrificed to cover this unpreparedness. Unbelievable from today's view. At that time, we had no clear idea, let alone knowledge of who to test, when to test, how to test, and last not least, what to test. Indeed, we had no idea at all what would expect us. Everyone spoke of the COVID pneumonia, not realizing that thrombosis, strokes, heart attacks, and gastrointestinal complaints would be just a part of the clinical picture. At that time, there was no general testing of all incoming patients, causing the virus to spread rapidly throughout hospitals and amongst personnel. And the rapid antigen test commonly used today for everything was not available for a long time yet. For us, there were no COVID guidelines we could have followed. And vaccination was not much more than a dream and still a long way off. Shocked and with scariness, we observed what happened in Italy in those days in March 2020. But thank God, despite the fact that the Italian doctors have been working day and night in this horror scenario, they have simultaneously set up and created a platform on Facebook to inform the rest of the medical world about this terrible disease and what was going on. They shared everything they found out, how they tried to handle the situation, and what we should expect. And with every ongoing hour, we have learned more and more about it at a time when the significance of COVID officially was still compared to the flu. A little later, mid of 2020, this was a time when the IFSO endoscopy committee under the leadership of Barham Abu-Dayyeh posted a statement on the practice of bariatric endoscopy during the COVID pandemic as an evident guidance for endoscopists during these hard times. Carrying together all available knowledge, it was described how and what to test. That a bronchoalveolar lavage was the safest specimen, followed by sputum and nasal swabs. PPE adapted to the situation and the patient's infection status was recommended. Hairnets, goggles, face shields, the right kind of masks and gloves, and for the first time in endoscopy, a negative pressure room was discussed and recommended in case of a confirmed infection of the patient. Indeed, we have scaffolded ourselves like we never did before. And we had to learn to triage our patients in urgent, semi-urgent, and elective, depending on their physical condition and needs. And unfortunately also how long interventions had to be postponed or maybe even had to be suspended. It was an attempt to shed light on the chaos around us and thus provide therapeutic certainty. The pandemic has now lasted much longer than we ever expected it would, comparable to a steady storm that we have to cope with. In reference to drama, this act is called retardation, and this expression fits the situation. Many patients were not diagnosed or treated during the pandemic, either because they were afraid to enter a hospital and catch COVID, or much more because hospitals were overcrowded with COVID patients and lacked capacity. Overall, significant fewer patients were treated than would have been normally. Suspension of elective procedures resulted in further weight gain of affected patients, thus leading to an individual intensification of their obesity disease. There is no official data, but we have followed this in our patients, and all colleagues asked reported the same. And all the suspensions of the elective treatments led to a backlog of endoscopic bariatric therapies with many untreated cases who should have been treated already, thus overall impacting negatively and resulting in an aggravation of the obesity pandemic in general. Therefore, from an endoscopist's view, there are two main negative impacts of COVID on obesity: the aggravation of obesity in the individual patient and the amplification of obesity epidemic itself, not only because all forces were joined to fight COVID. We do not yet know how many of our patients have deteriorated or died during the waiting period. Exact evident data regarding this query are not available as of right now as well. Finally, it seems there is light in the end of the tunnel and the last act, the denouement, arrives. As Einstein said, reality is merely an illusion, albeit a very persistent one, and this fits exact the context. It is obvious and reality that we will have to live with the virus, but there is still a little bit of hope that the rest of the world will be vaccinated as soon as possible, even sleepy Europe. Israel and the USA have set a good example. And above all, let us get back to treating our patients with full speed to fight the obesity pandemic with the same force we have been fighting COVID-19. With that, let me end and thank you very much for your kind attention.
Thank you, Dr. Stier, for a great philosophical discussion. And now I'm going to have Dr. Ivo Boskowski present the gastroenterologist perspective.
Hello, everybody. I'm Ivo Boskowski, and I will talk about the impact of the COVID-19 pandemic on patients with obesity and the point of view of the gastroenterologist about this situation. So these are my disclosures. COVID-19 is a systemic disease. We know this very well. At the beginning, we thought this was a severe respiratory syndrome, but now what we know is that this is a very complex disease that can affect any organ in the human body, and from vascular, cardiac, kidney, and so on, and especially the gastrointestinal system with as a consequence disorders in this district. So the impact of the COVID pandemic in obese patients in gastroenterology can be in obese patients with gastrointestinal disorders that need hospitalization and are COVID negative, and obese patients with gastrointestinal disorders that are COVID positive and are symptomatic. We know very well that obesity is a negative prognostic factor for the infection who is affected and has more than 25 of body mass index, is more prone to complications. If we associate this with COVID, we'll see what will follow. So correlated with nutrition and obesity, we know that obesity is one of the most important epidemiological factors that underline the susceptibility to COVID-19, and potential interactions between the nutritional status and the immune function have been widely documented. So this is what we already know. What we just recently has been published, what we just learned is that when you have patients with overweight and obesity, undernutrition, and other diseases that are connected to obesity, hypertension, cardiovascular diseases, and so on, especially lack of some vitamins like vitamin D, A, C, and so on. Here is also involved the ACE2 receptor and the binding sites for vitamin D. There is competition between the virus and this one. All of this in the complexity of the situation with obesity can lead to a dramatic situation, especially from gastrointestinal point of view. So in gastroenterology, there are many districts that in the obese patients are already involved in most of the patients, like fatty liver disease, intestinal problems, inflammatory diseases, common bile duct stones and gallbladder stones, polycystic ovary syndrome, diabetes, and so on. Why ACE2 is important? Because, as I said before, there is competition for especially for ACE2, and it is both expressed in the lungs and in the intestine, and not only ACE2, also the transmembrane protease, serine protease 2 proteins. We have published this recently regarding the thrilling journey of the SARS-CoV-2 into the intestine, from pathogenesis to future clinical implications. So we have seen we have postulated that both the lung and the epithelium express, we know this, the ACE2 receptor that is recognized by the SARS-CoV-2 virus to entry in the host cells where the virus starts to replicate. And in the lung, once the virus has entered in the cells, it prompts immune cell activation characterized by pro-inflammatory cytokines and immune cell recruitment. In viral clearance is not sufficient. The immune response further progresses toward cytokine storm syndrome in the gut. The virus targets the cells and elicits the immune response in a similar fashion. So also it is not yet clear whether the magnitude of the inflammatory response reaches the same level in the lung. We do not know this. The evidence of the gastrointestinal infection of SARS-CoV-2 can be nicely seen here. This is a histologic and immunofluorescent staining of esophagus, stomach, and duodenum and rectum. And this had been also nicely shown. What symptoms are usually described with what gastrointestinal symptoms are described with the COVID-19 infection are anorexia, diarrhea, vomiting, nausea, abdominal pain, and gastrointestinal bleeding. The incidence of digestive manifestation in this review of the data from 2023 patients was higher in the later than in the early stage of the epidemic. You see here we mentioned gastrointestinal bleeding in 4% of the cases, up to 13. We have also described this in an international multicenter study. you can see what kind of lesions can be seen in the intestine, and obese patients were 13.5 of the cases, and the disease was severe. COVID-19 or SARS-CoV-2, COVID-19 is a disease. SARS-CoV-2 is an infection. The virus can be found in the stools in half in the patient. It is not too much. So, but how to reduce the fecal persistence of the virus of the RNA? There is no evidence based from China. This is speculation. We can postulate the role of the gut microbiota in COVID-19 infection. Probably yes, we do not know. This has been shown in Nature in 2006 when COVID-19 didn't exist, but the gut microbiota has thousands of implications in the human body, so probably there is correlation. This is also speculation. What could be the correlation between the infection and what can happen with the intestine is IBS, irritable bowel syndrome. Here we have the low-grade inflammation that is caused by the infection of the SARS-CoV-2, the microbiota alteration and altered gut function that could lead to the irritable bowel syndrome. And what about IBD? Of course, we are not talking about Crohn's disease because Crohn's disease in the obese is really rare, more ulcerative colitis. Even if these patients, even if they take the anti-tumor necrosis factor alpha, like infliximab, Humira, and so on drugs, and there is the immune system answers in a different mode in these patients. There is immunosuppression. From the literature, we know that there is not great impact of in case of infection of COVID in these patients. So if there is no other data, there are a lot of speculations also here. What we can say that there is also here high concentrations of AC2 the receptors in the terminal ileum and colon, and there is competition both for the receptor. And despite the fecal shedding of the SARS-CoV-2 in half of the patients, there is no clear evidence that the virus is spread via feces and infection occurs through the intestine. So no current evidence of increased infection rates or worsening of the disease severity of COVID-19 in IBD patients can be registered. And in the end, of course, the obese patients are very complex patients. Obesity, dysbiosis, polycystic ovary, and NAFLD, and insulin resistance can be all together in these patients. And if we add plus the COVID-19 syndrome and the infection of SARS-CoV-2, of course, we can imagine, and the interleukin-6, we can imagine the impact in the human body of the obese patients and the fragility of these patients. So what we can suggest, the special measures in obese patients with GI disorders should be adopted for infection preventions. And of course, these patients should have priority in vaccination. Thank you very much.
Thank you so much, Ivo. And now we have Julie to talk to us about nutrition and COVID. Thank you very much.
Thank you for inviting me to speak on the impact of COVID-19 pandemic on patients with obesity and nutrition. We'll briefly look at the immune system and micronutrients, interactions, deficiencies, supplements, diets, and prevention. 39% of adults in the world are overweight, with 13% of these adults being obese. In addition, we know that patients with obesity have some pulmonary dysfunction, comorbidities, chronic inflammation, and hypercoagulability. With COVID-19, the SARS-CoV-2 virus binds not only with ACE2 receptors in lungs, but spreads to other organ systems also with the ACE2 receptors, GI tract, adipocytes, heart, and kidneys. Thus, the immune system is dysregulated in patients with obesity. These factors are responsible for the disease severity and poor outcome in patients who are obese with COVID-19. We need a balance within the immune system to keep inflammation regulated. So how can we achieve this? The micronutrients listed in the box have key roles at every stage of the immune system, including creating physical barriers and being integral to the innate, inflammatory, and adaptive immune responses. Thus, the immune system requires micronutrients to function normally. There's been a great amount of research looking into micronutrients and combating the COVID-19 dysregulated immune response. We know that adipocytes in obesity release primarily pro-inflammatory cytokines such as interleukin-6 and tumor necrosis factor alpha, while adipocytes from lean individuals release more anti-inflammatory cytokines. Thus, the immune system is dysregulated in patients with obesity. We see the omega-3 fatty acids represented by the shark and vitamin E, C, and selenium up at the top of the slide. These act through antioxidant pathways to decrease the risk of infection. Zinc is a unique and vital mineral during COVID-19 infection because of its properties in modulating both the immune and the antiviral response. All of these micronutrients are involved in a fully functioning immune system. This slide shows the prevalence of micronutrient deficiencies in patients with obesity, a BMI greater than 35. However, under some conditions, deficiencies in a nutrient could be increased, as we see with vitamin B12. Patients who take PPIs have a 50% increase in B12 deficiency. When we look at zinc, we see a 24 to 28% prevalence of deficiency. So we might assume that zinc deficiency occurs in 1 out of every 4 patients with obesity. Zinc and other micronutrient deficiencies may result from a nutrient insufficient diet, poor or absorption, excessive loss of nutrients, micronutrient redistribution in intracellular and extracellular components, or a combination of these factors. We're unable to look at all the nutrients and their interactions, but we can look at zinc as an example. So zinc is a catalyst for hundreds of different enzymatic reactions throughout the body, including antioxidant function, digestion, skin integrity, etc. So what might early deficiencies look like? With the skin as a barrier, we might see rash. We might also see a change in or absence of taste, which sounds somewhat familiar for COVID-19. And we might also see a weakened immune system with recurrent infections. Zinc deficiency is also associated with insulin resistance, elevated inflammatory markers, and impaired immune system and antiviral response. Under some conditions, micronutrient deficiencies develop because of impaired absorption. Here are a few examples. Iron and zinc taken in large doses can inhibit absorption, so take therapeutic doses separately. High dietary zinc intakes decrease copper absorption by increasing copper sequestration in the mucosal cell bound to metallothionein and increases fecal excretion of copper. So take 1 milligram copper for every 8 to 15 milligrams of zinc to avoid a copper deficiency. Don't take more than 40 milligrams of zinc, which is the upper limit, daily. Albumin is the primary transport protein for some micronutrients. If albumin is decreased, then micronutrient levels will also be decreased. So can't we just take a pill? Sounds easy, but it's not quite so straightforward. For instance, there may be medication interactions affecting zinc or other micronutrient status. Make sure to look up potential interactions with some of them listed here: diuretics, ACE inhibitors, acid-reducing meds, antibiotics, and hormone replacement therapy. So it's best not to assume that if one dose is not working, that more is better. Don't recommend a higher dose without considering potential interactions. Different supplementation strategies will vary for prevention versus treatment of the SARS-CoV-2 infection. So we're currently focused on prevention. So how do we get enough zinc and other micronutrients? Under what conditions? What about our diet? So, okay, what about diets? We can see here that some of the foods pictured are part of a Western diet, which will not provide much zinc or other micronutrients. In fact, excessive eating of ultra-processed foods with low nutritional value can contribute to inflammation and even more micronutrient deficiency. So let's look at some good food sources of zinc, and the foods here are listed by a realistic serving size and the amount of zinc provided. For example, a 3-ounce portion of beef, lamb, or pork gives 4 to 10 milligrams of zinc. For those of you working with patients who use liquid meal replacements, typically a higher protein, a typical serving will provide 2 to 3 milligrams of zinc. This is usually 25 to 30% of the daily recommended zinc per serving. In the US, the daily recommended amount is between 8 and 11 milligrams. In the UK, it's somewhat similar. However, the recommended level depends upon dietary phytate. Okay, what about other diets? Research shows that 3 of the diets listed in the table do have anti-inflammatory properties. So the Mediterranean diet is rich with monounsaturated fats, fiber, and omega-3 fatty acids. The plant-based diet emphasizes whole, minimally processed foods. It does not include animal sources of protein, so we may encounter some missing nutrients. The DASH, which is Dietary Approaches to Stop Hypertension, emphasizes servings and portions, and it does allow more sweets per week. The ketogenic diet, it focuses on macronutrients, limits daily carbohydrates intake to less than 50 grams with fat as the primary macronutrient, followed by protein. It may reduce weight, but without dietary modifications, the research shows it increases intestinal inflammation. Intermittent fasting based on timing, eating during a specified time period. So there may be strict or liberal food choices. Intermittent fasting may be anti-inflammatory, however, only indirectly via weight loss and food modifications. If you aren't familiar with the Mediterranean diet pyramid, this infographic is a great illustration of foods to consume with meals every day and weekly as you proceed from the bottom of the pyramid up to the top. It's available in 11 different languages, and I've put a link in the references for you. The Mediterranean diet is an anti-inflammatory diet that limits foods consumed in a Western diet. It includes the variety and amount of foods that could potentially meet all of a healthy person's dietary needs. But for patients with obesity and those who contract COVID-19 and may become long haulers, the need for micronutrients may be much, much different. So, in summary, micronutrients. Assume that patients with obesity are deficient in one or more micronutrient and screen for deficiencies. And this is pertaining to patients with obesity. Count the amount of micronutrients from all sources to ensure an adequate daily intake. Avoid taking micronutrients at the same time as some other prescriptions or medications, or even other micronutrient competitors. And with regard to diet, decrease your intake of high sugar, fat, salty, processed foods. Lose weight to improve health. Use any of the above 3 diets or metabolic and bariatric surgery. Following these principles can help to avoid a dysregulated immune system and therefore decrease your susceptibility and the severity of COVID-19. Thank you very much. I do have 3 pages of references if you are interested. Take care.
Thank you. Thank you very much for that great presentation. And now I'd like to invite our panelists and speakers. We have a lot of questions from the attendees, and other attendees, if you have other questions, please feel free to ask on the question section of your box. So I'd like to start with both Dr. Shakura and Dr. Steer. When you're doing any type of either endoscopy or surgery, are you still asking patients to get COVID tested beforehand? And also Dr. Morton, if you want to comment on that too.
But if I might start, yes, we do test every patient still.
Same with us, yes.
Same here, absolutely. We test
Yeah, we do
everybody.
all something.
And same here. I don't think that's going to change anytime soon. Dr. Aroni, we touched upon sort of the GI aspect of obesity, surgical and endoscopy. Do you want to sort of give us how you think it's affected your patients with obesity, either in numbers that you've seen come up after the COVID pandemic opened up, or just how they've affected them?
Interestingly, Dr. Shariah, well, first of all, thank you for having me at this meeting. I wish we could all be somewhere together, and I look forward to next year. But interestingly, there has been a massive increase in interest among patients who want to lose weight. Our volume of patients has increased at our Comprehensive Weight Control Center by over 15% in the past year. Despite the interruption, where for almost 2 months we saw almost no one. When you look at the year as a whole, our patient volume was increased. What we do is perfectly suited to telehealth, which is mainly advising patients on their diet and adjusting medications. We prescribe medication and have gotten good results. We see a lot of surgical patients, post-surgical patients. And so when you look at the link between obesity and COVID severity, which I think is irrefutable, I think more people are recognizing that if they want to avoid severe COVID, they may be interested in losing weight. So I think that what we've heard about stopping bariatric surgery being a bad idea is absolutely true. And I would point out one study earlier this year published in SWORD from the Cleveland Clinic, which was a case control study showing that of patients who had had bariatric surgery, 18% who were COVID positive were hospitalized versus 45% of matched controls, 18% versus 45%. None of the patients who had bariatric surgery wound up in the ICU, mechanically ventilated, or dying, versus substantial numbers of patients in the control group who had not lost weight. So I think that we're really understanding the physical burden of severe obesity, and I think that surgery and all of the treatments that we now have are should be more supported by insurance here in the US and elsewhere. I think it's pretty clear.
Hopefully someone somewhere is listening from the insurance companies. Dr. Sharma, I wanted to ask you sort of the same question about patients you've seen in Canada. What have you noticed in the last year or so? You're muted.
Well, sorry about that. Well, thanks for having me on the panel. Well, obviously, one of the biggest differences is that now virtually all of our patients are seen virtually. And this turns out to actually have a lot of advantages. You can increase the number of patients you're seeing. You can see them more frequently. In our clinic in Alberta, sometimes patients have large geographic distances to cover. Sometimes they drive 6 hours to get to the clinic for a 15-minute appointment. So that has all gone away. And I think that this virtual medicine, at least for patients who are in follow-up, I think is going to stay, because it's once you figure out the how to do it, and once patients also get comfortable with using the technology, which everybody has on their iPhone or their smartphone, has actually proven to be quite efficient. In terms of the impact on the patients themselves, it's quite interesting, because you hear two stories. You hear the stories where people are stressed out, they're economically stressed, they're stressed because they're at home, the kids are at home, they're worried. And there's certainly an increase in stress eating there. There's probably less physical activity because all of the gyms and recreational facilities are closed. We also had a pretty prolonged winter, so people weren't able to go outside. So those are the negative impacts. But I've also heard from a lot of patients about positive impacts. And these include the fact that you're much more in control of your day. You don't have you have a lot more time on your hands because you're no longer commuting, 2 or 3 hours a day to wherever you need to go. A lot of people have taken up cooking, meal preparation at home, something that families just would not do before. You remember the early part when the supermarkets ran out of yeast and flour, at least in Canada, because everybody was baking their bread. And a lot of that, those changes in eating habits where families are sitting together and home cooking is happening. People who didn't have time for physical activity before actually started physical activity now at home, again, using all kinds of online resources. We know the sale of, the sales for exercise equipment went up radically when the epidemic started. There's also another interesting aspect, and and I've heard this, from a lot of patients who say that not having to leave the house no longer exposed them to the daily weight bias and fat shaming and fat talk that they're exposed to every time they leave their house, which it turns out is a huge psychological stressor for a lot of patients. Having to go out, and then if you're in a work environment, there's teasing, there's bullying, there's there's potluck lunches where you can't refuse to partake in. So there's a lot of those type of negative impacts that people did not have to cope with just because they were now, like I said, in better control of their life. So I've heard both stories. So we've had this negative impact, and there's people who are complaining and saying, this is out of control. My weight's going up. I'm less physically active. I've got more stress. There's more depression, more anxiety, other things going on, relationships breaking up. We've heard a lot about those kind of issues. But I've also heard a lot of positive stories, and we'll see how much of this remains. I think a lot of the home office stuff is going to stick on, and I think virtually care for probably not just for obesity, but for all chronic diseases has been dramatically changed, and I think that's going to stay changed.
Great. For Dr. Mortson, due to the ease of lockdowns, maybe because of vaccination and the rates dropping lower, do you see an increase in the number of surgical patients presenting with advanced stages of disease requiring bariatric surgery?
Well, thank you to WGO and to IFSO and Reem for putting this panel on. We definitely have seen more interest and patients for bariatric surgery. In fact, it's been like a J-shaped recovery for us. And I think people have started to pay more attention to their weight. We know the two biggest risk factors for COVID are age and weight. Only one of those is modifiable currently. And so we have seen a lot more interest in it. And I think to Scott's point earlier, we never again want to see bariatric surgery stop. That delay does lead to more complications for these patients. And as a mitigating factor, we put patients on medications when we didn't have options like GLP-1s. It also had a big financial impact on hospitals. It demonstrated how much elective surgery matters for hospitals. We are now recommending 3 months of cessation for surgery after the COVID diagnosis because it correlates very well with that peak of inflammation. And we know if anything about obesity, it is a disease of inflammation. Like Lou and Dr. Sharma have indicated, there are some big lessons to be learned. Telemedicine is here to stay, but I would add telehealth will come forward too. And by that, I mean, we're going to look to do remote monitoring of some of our patients after surgery so they don't have to stay in the hospital for so long. And I think at the end of the day, we're also going to be seeing this population of the long haul COVID patients. So a lot of lessons. And so far, we've seen more interest. The lockdown has resulted on average in 30-pound weight gain through a couple of longitudinal studies. So I think we're going to see more and more impact from this.
Lou, to follow on with that, are you seeing more patients sort of interested in the BMIQ platform? I know that there are other platforms out there as well, just increasing the telehealth component.
Yes, our program is now called IntelliHealth Evolve, and we've spent years building, testing a whole telehealth platform to deliver obesity medicine care, which includes evidence-based algorithms to support the use of medications that we use, as well as all the behavioral tools. And what we're seeing is enormous interest by insurance companies. So we've taught nurse practitioners at one of the large insurance companies how to use our approach. They've treated their employees, and what we're seeing is a cost benefit that's positive. And if you look at the barriers to getting insurance coverage in the United States for this kind of care and around the world, I think it's grossly underutilized. The obesity treatment, you will all agree that 2 or 3% of people who qualify for the kind of care that we offer and you offer is 2 to 3% are getting it at most. But what we're seeing is a positive return on investment from both behavioral care alone, using our telehealth type programs, as well as the medical programs. And the point of using this type of platform is that the insurers are nervous that they're going to be throwing money out the window and not getting the results that they're paying for. So by using these types of platforms, you can actually report back results and they can feel confident that they're getting their money's worth. And we actually are showing insurers this. So several large insurance companies and healthcare companies around the country are now in the pilot phase using telehealth to scale up programs, obesity medicine programs. And I would expect that this is the beginning of a shift, because it's now not only cost beneficial to the payer, but the endocrine division at Weill Cornell could potentially make money. And if you look at academic centers, this is not a money-making endeavor. It's been kind of a loss leader. If we could actually make money, because it costs less to house people, they can work from home, we may actually see obesity medicine as a field begin to grow in academia. And I think that will be good for our surgical colleagues, our GI colleagues, because we're the biggest referrers for those procedures. When obesity medical treatment doesn't work, we're referring to our colleagues all the time. So I believe we're at the beginning of a pivot towards obesity medicine and surgery and GI procedures. I really do.
Thank you. We have a couple of questions for Dr. Sikora. Mainly one was technical about the method of bariatric surgery, whether you would use open endoscopic or laparoscopic to reduce the risk of infectivity. And is there a need to increase the precautionary measures in these different approaches?
To answer the second one first, I think we need to increase our protective behavior from where it is now, but it should be the same for everybody at all times. We should always have that protective gear on and double gloved and eye covers and all that, waterproof. And I think that should be for any case, not just those with patients with COVID or the risk of COVID. As far as the first one, there's no literature on it, but I don't think anybody does much open surgery anymore. And I don't think this is an indication for open. I think that might be more risky than laparoscopic because of the big open field and the likelihood of droplets or small amounts of fluid getting onto the operative team would be greater. I really can't comment on endoscopy. Obviously, that's also an area where you'd have a lot of the potential for droplets and for humidity to spread virus, but I don't know of any papers that suggested that was in fact the case. So I think the most important thing are the precautions. Keep the people in the operating room limited to only those that are necessary for the opening and the closing. Use smokeless equipment. Protect yourself by double gloving, eye covers, waterproof gowns, etc. And I think, once again, my opinion is that should be for all cases, because it can be an issue with the next virus that comes around as well. So we should protect ourselves at all times.
Don't forget vaccines. That's the ultimate PPE.
I agree, and there's a sort of a question on that, and that was to Ivo. How do you encourage your patients who are sort of hesitant about getting the vaccine? Do you sort of tell them that it may improve some of their GI symptoms or some of their long haul COVID symptoms, or what's your approach with that? But just before you answer, I just want to comment that it's universal precautions, and what we had to sort of talk to our hospital about is that we don't know who has COVID or who has other diseases that are unknown to us, and we should always dress the same and act the same regardless of what we think or know about our patients.
I think that came out of the experience with HIV, which was the same thing. We had no clue about the virus, how it reacted, how did it spread, how do you protect against it? And at the time, surgeons were very casual about even eye covers. So their eyes were exposed and the water droplets could get up through the mucous membranes and into the body. So I think now there's more of an effort to have universal precautions, but it should be for every case, regardless of who the patient is, because you just don't know what the exposure could be to any given person coming to the operating room.
Yeah, I can add something to this. You know, obese patients, basically, they know that they are fragile. So they do protect themselves. If you talk with them, they will say they mostly stay at home, or when they go to work, they went really protected. And this was my impression every time when I spoke with them. Now, when vaccines came, most of the questions were, which kind of vaccine should I do? Should I do this one or that one, and so on? So my answer was that is what I think, that the vaccines almost are all the same. So whatever they do, as soon as they're protected, that's good, because all behind, I think, is politics. That from a second, what I would like to add besides that is that we just published a paper in Gut on COVID, on endoscopes used in critically ill patients that were COVID positives. COVID positive, we did swabs on those endoscopes because we aim to evaluate our process of endoscopes reprocessing. And what we found, we could not complete the study because all the swabs down immediately after endoscopy in COVID positive patients were negative. We did swabs on the endoscopes, on the valves, on the channels of suction, and with that, we did that also on bronchoscopes. So yes, we do use gowns, we use N95 masks, we use face shields, but then probably the risk of infection, also of aerosolization of the virus, is lower than we think from one hand in endoscopy. From the other, it is enough to stay close to a person that is infected to get infected. And there are many, many things that we still do not know about this virus.
So true. Julie, can you comment on, we talked a little bit about telehealth and sort of the surgical, endoscopic and obesity aspect, but what about nutrition and dietitian consultations? Have you noticed the shift? Has it, compliance? Tell me about that.
Well, as an outpatient dietitian, in one particular clinic, the volume essentially tripled. So, you know, there's always mention of professional or practitioner burnout. So I always say that we had indirect, you know, effects of COVID-19, not that we were directly interacting with a patient who's infected, but because the volume when increased, you know, or increased dramatically, then the wear and tear on the practitioners just became unbelievable. So that's, I guess, one particular thing. And then another that I found kind of interesting in listening to you guys was the fact that I do hear more from my patients that they are starting to really take some of these, what they call anti-inflammatory or anti-COVID supplements. And so that's a little bit concerning, especially with some of them like zinc, because you can pretty quickly get into deficiencies in other nutrients. And there's still not the knowledge of, you know, how much there's a balance, you know, especially with somebody who becomes infected with COVID-19. You know, there's going to be this protective mechanism that the body does to sequester some of these nutrients, but yet the body still needs enough to provide the functioning immune system.
So that's one area when I was doing all this research that is still just, nobody knows. Assays, if we're telling patients to go screen these vitamins, go get this lab done, there's no accurate lab for zinc or for vitamin C. So I think we all need to become much more proficient in our clinical skills and acumen. You know, how do we know what a deficiency looks like? Because a lot of times these labs may come back normal, but the person has symptoms that indicate a deficiency.
Very, very good point. And that was sort of a part two. Someone had asked you a question about what labs to measure. Ivo, there's another question for you on, now that we're seeing more patients with higher stages of GI diseases due to the lockdown, what are you seeing typically, and how has it hindered or helped your management?
So yes, most of the patients belong to the IBD group that could not access the health system because they were afraid to come to the hospital. You know, patients with IBD once per month or something like that are getting anti-tumor necrosis factor alpha drugs and similar. So those patients, some of those had really relapses of disease. You can imagine those patients with Crohn's disease and fistulas. You have seen, I'm not directly involved in the treatment of IBD, but I work close together with the colleagues treating those. So it was really an emergency. And the other thing is in endoscopy, because since we were doing only emergencies, as everywhere, there is rise in colon cancer diagnosis, and this is another pandemic, because now that we started doing the screenings and doing follow-ups and checking patients, we're seeing things that were not seen for 10-15 years. Almost every day there is cancer, almost every day there is something strange, neuroendocrine tumors, and so on. Probably before we were doing too much screenings, but in the past year and a half we did only a few patients, so it's natural to have this.
I agree on that. We've actually now in the US decreased the ages when to start screening to
45.
Which I think we're seeing a lot of patients with polyps, and we've heard the cancer obesity talk earlier, and it just goes to show that they all go hand in hand. Christine, I wanted you to comment on sort of what you're seeing with you have both the prongs of endoscopy and surgery, and how are you seeing COVID affect your practice, and how has it changed over the last few months with everything opening up?
I just can echo what Scott said before. All the elective procedures were suspended in Germany, and the drama is that bariatric patients are called elective, but they aren't. And what I really wanted to know is how many of those did die on the waiting list. And I know in our cohort, surely 1 or 2. And this is really a question I would spread around, and we all should find out this, because it's very important. This is really a big problem, because as we heard earlier today, obesity has a real high input on cancer, a really high input with comorbidities, and it was really not right to suspend all these elective procedures. And this is a pity. We have a long waiting list of patients now for both endoscopy and surgery.
So
it's been a real problem for us as well, not only for elective, but even some of the semi-urgent. We have a paper we did showing that the cholecystectomies and appendectomies were more advanced in that time period, because people just stayed home. And you saw that with heart attacks too. So people need to come back. There's a movement to ask people, make sure you come back, don't delay.
Yeah, absolutely.
So we talked about sort of presenting to surgery or presenting to endoscopy for obesity treatment. What about, have any of you noticed? I mean, I definitely noticed sort of the COVID-15 or COVID-19, however you want to call it, with patients that have already undergone some sort of treatment for their obesity, either endoscopic treatment or surgical treatments. They've all, over the last year, gained some weight. How are you all coping with that?
I think there's been a variety of responses. So we've seen people lose weight because they're not going out eating all the time. So we have people who entertain for business, for example, and they're cooking at home. Those people, I would say, by and large, have lost. But then the majority of people have gained weight because they're very inactive and maybe comforting themselves by eating more fattening food, ordering out a lot. So I think, we've seen a lot of weight change over this period of time, not as much weight stability.
And I would add to that, it's not just the eating more. I've also, had conversations with patients about their alcohol intake, which has also gone up dramatically because they no longer have to drive. They're sitting at home. The glass of wine that you have at home is usually twice the glass of wine that you would get in a restaurant. So serving sizes is certainly an issue. So, that's also a source of calories. So, it's like, I mean, all of you have seen this and Lou's alluded to this. It's been very heterogeneous. For some people, this was the right thing at the right time, funnily enough, but for a lot of people, it's a problem. So, which again goes to show how heterogeneous this population is. Because in obesity, if there's one thing we've learned is that one size does not fit all, and this was to be expected, that people are going to respond very differently depending on whatever is driving their weight gain, whatever is affecting their lives. So we're not surprised by this, but it is certainly very interesting to note.
We certainly have seen more weight gain in of our bariatric patients. And those longitudinal studies were pretty compelling. Most people gained weight, Upper West Side, notwithstanding Lou. But we see those patients now are even in more need of surgery or medications. And what we've probably done is work harder to get some of these patients to lose weight before surgery, because we know stage of disease will determine effectiveness of response. So we're doing our best to kind of mitigate some of that weight gain, but it certainly has happened. But that the other side of the coin, a lot more interest than there was before. So we have a big time period now between seeing patients and then going to surgery, and so working hard on fixing that so we get patients taken care of.
I completely agree. It's the same. It's the same in our department. We have a big time span between seeing the patients and doing the operations. And agreeing with Aya, yes, it's very heterogeneous. A lot of patients gained weight, but there was indication that that younger patients who normally eat from the fast food restaurants, they lost a little bit of weight because it wasn't available for them. But the other patients who really eat because they have anxiety or whatever, they really gained. And the greatest part of our patients also gained weight.
I would agree.
I did want to make.
Go ahead.
I was just going to say real quick, Scott, that we have one study where we looked at long-term results after COVID positive patients that got operated on after they were 3 months out, and the effectiveness of the operation is not diminished. It's the same as COVID negative. So something to keep in mind, because people ask, oh, I was COVID before, is this still going to work? It does work, and that's true of the medications too.
Yeah, and that's
I've been
why
surprised. I'm so sorry, Scott.
I was just going to say, that's why I felt the criteria that you had not had a COVID infection was ridiculous.
I was just going to say that I've seen a big upsurge, just to plug this, patients actually doing more exercise in home. So that was really kind of fascinating. It's like, how are they making the time? How do they have the space? But many of the patients I've met with are doing that.
It's true. Thank you all very much for a very lively discussion and great presentations. And it just goes to show you that the sort of the two pandemics really do intermingle and mix, and we have a lot to learn. I'd like to close this session and invite Dr. Lilian Cao and Dr. Guillermo Mercado to close our session. Thank you.
Thank you very much.
Moderating.
Thank you.
Thank you.
Thank you, everyone. Well, ladies and gentlemen, friends and colleagues, I hope you have found this World Digestive Health Day 2021 webinar on obesity and ongoing epidemic as interesting and inspiring as I have. We could not have a more esteemed faculty today, and I sincerely thank all our speakers and panelists for their time and for sharing their knowledge with us today. I would like to take this opportunity to thank our sponsors for their support of this wonderful collaboration between the two federations, IFSO and WGO. So I'd like to thank our platinum sponsors, BioCodex, our silver sponsors, Apollo, Baxter, and Gore, and many thanks to Ethicon and Medtronic for their continual support to IFSO as well as WGO. It's also important to thank the people behind the scenes. And these are the people who have made 2021 World Digestive Health Day possible and for making the webinar run so smoothly. Firstly, I'd like to thank Manuela Mazzarella, our IFSO Chief Operating Officer, Marisa Lopez, Executive Director of WGO, Megan Uhlenhaker, Program Manager for WGO, and Stefania Ekenfora from MGM for the smooth organization of this meeting. Last but not least, I would also like to thank and acknowledge Professor Jim Tooley, who's a past president of WGO, who has been instrumental in bringing together IFSO and WGO. Many thanks to you, Jim. And for future planning, I would like to invite everyone to the 25th World Congress of IFSO 2021. The silver anniversary will be in Miami in October 19 to the 23rd. Finally, a big thank you to both my co-chairs, Professor Ghulam Macedo and Professor Reem Sharaya. It has been a privilege for me to share the co-chairs with both of you today. Hence, I'm going to give you both the last words on this wonderful World Digestive Health Day webinar.
Thank you, Reem. Probably you want to say some words now, because I was overwhelmed by our conclusion for Professor Lilian Cao. Thank you so much for your words, very kind words. Also for the fact that and acknowledging Professor Jim Tooley, that was really with us all the time, and he was really instrumental for this wonderful joint venture from WGO and IFSO. And just a final word for telling that at the end of this year in December in Prague, we'll have our annual meeting, WGO with international meeting with the Czech Republic and in Prague, so that, and we all invite you to participate, hopefully in a hybrid situation, which means that fortunately we think we'll be able to get along with each other physically, which is great. Thank you.
I have nothing to add except to say thank you so much. It was great collaboration between WGO and IFSO, and we hope everyone enjoyed the day. And thank you to our sponsors and to our behind the scene people who helped us make this a success.